Good evening, dear students. Welcome to the MIQ series by DocTutorials. And we are continuing the series, this time taking care of anatomy. I'm Dr. Kaushal. And you have been given some of the MCQs, 20 MCQs. You already would have gone through that. And now we are going to discuss the answers and the explanations. You are preparing for your FMGE exam in January. And we are trying to bring the most important questions, which will be taking care of most important topics for the upcoming exam. I'm looking at the chat also, and as your queries will come, I'll try to entertain those as well. So starting with the very first question. So starting with the you were given one question asking about the pterion, and what do you think could be the answer here? So as we talk about pterion, a lot of questions are coming on pterion. H-shaped suture, the weakest point on the lateral aspect of the skull. One of the person riding a bike without helmet, road traffic accident, fracture here and a bleed. So that kind of questions come. So what do you think? Which of the following is true regarding the pterion? Is it formed by the articulation because it is H-shaped suture, 4 bones are there? Is it formed by frontal, parietal, temporal, and occipital? Before we look at the options, let us look at a diagram that will be helping us. You see, this is one diagram where we are showing the lateral view of the fetal skull, means the baby is already born and there are some fontanelle gap between the skull bones, the fontanelle, and there will be some names given to them. There are many, but 4 of them are important. So as you will notice, the very first we are focusing upon is on the front, the anterior. So anterior fontanelle. You see here, this is the anterior fontanelle, and we can mark it. It is a gap between the skull bones, and on the front we have the frontal bone, and on the posterior side we have parietal bone, which is marked here. So that is anterior fontanelle. Then we have a posterior fontanelle, and posterior fontanelle, as you can see, is between parietal anterior, and then you have occipital bone posterior. So that will be posterior fontanelle. Then we are having the posterolateral and anterolateral. Posterolateral is also called as the mastoid fontanelle because it is relating with the mastoid part of temporal bone. So a third bone has come. Mastoid part of temporal, the occipital bone and parietal bone. That is what is making this fontanelle, which is basically the posterolateral fontanelle or mastoid fontanelle. Then there is this one which we are focusing upon, anterolateral fontanelle. Now, anterolateral fontanelle, as we are looking at that, what are the 4 bones? That is the point we were asked. As you can see, on the front we have frontal bone, posterior superiorly parietal bone, then posterior inferiorly the squamous part of temporal bone. Now be careful about these names. Squamous part of temporal bone. Earlier the examiner was asking you temporal. Now he may ask you squamous part or mastoid part. Mastoid part is for posterolateral fontanelle. Squamous part is for the H-shaped suture, which is later it will coming. And then you have greater wing of sphenoid. Because you have greater wing of sphenoid, that is why it is also called sphenoid fontanelle. Now there is a gap. That gap has to seal, and it will happen after birth. So when are they going to close after birth? I will give you a trick. You can use that trick, and the trick is simple. Just remember, the first to close is the posterior fontanelle, and say 3 months. I must tell you that different authors will give you different values, so you have to remember some of the values. Like posterior fontanelle will close at 3rd month, closure 2 to 3 months, 3rd month. Now most of the books, including laser anatomy, will tell that the second to close is here, that is the sphenoidal fontanelle, and that is also 2 to 3 months. But then it may take some time, and sometime it is 6 months also. So because it is 6 months, what I'm doing is I'll multiply 3 months into 2. and when you do 3 into 2, that comes 6. It will be closing my 6 months. So remember, it is 3 to 6 months. The anterolateral fontanelle, 3 to 6 months. Then third one to close is the posterolateral fontanelle. And how do you reach the answer? Whatever you got here, 6 multiply by 2, 6 into 2. So 6 into 2, that will be 12. So it will be 12 months. This is closing 12 months. So 12 to 18 is the range which you will get in different books, but you can take it as 12. And the third one is to close. Last one, fourth one, is the anterior fontanelle, and it is whatever you got here, 12 months into 2. So 12 into 2, that is 24 months. So it will be closing my 24 months, but then it is a range, 18 to 24. I'll repeat the trick. Trick is, the first to close is 3 months. 3 into 2, 6 months. 6 into 2, 12 months. And 12 into 2, 24 months. So that will give you one basic idea. Last to close is the anterior fontanelle. And if you look at Gray's Anatomy, it will tell you the anterolateral fontanelle closes by 3 months. But you keep it 3 to 6 months, that range. With that, you can also continue discussing some other facts like here. We want to find which of the following is true. So what do you think? Choice A is not true. Why choice A is not true? Because as we have already mentioned, if you are telling about the pterion, it is formed by articulation of frontal, yes. Along with frontal, you have parietal, yes. The squamous part of temporal, yes, but not occipital. It was greater wingosphenoid. So because it is greater wingosphenoid, not occipital, it is a wrong option. What about option number B? Is it formed at 3 months? That is correct, and that should be the answer. This should be the answer that is correct, because we have mentioned when the anterolateral fontanelle will close, it is 3 to 6 months. So when it will close, what will come in that place? In that place, the H-shaped suture. And what is that H-shaped suture? The pterion. So the answer to this question will be choice number B. What about choice number C? It overlies the stem of the central sulcus. Is it central sulcus or lateral sulcus? It is not central. This is wrong. It is lateral sulcus, and which is also called as Sylvian sulcus, and that is why it is also called as Sylvian point on cerebrum. Let me show you in a diagram. Say you draw this diagram of the cerebrum. When you draw the diagram of cerebrum, you'll find that cerebrum will have some sulci. The one which you are seeing right now is the lateral sulcus. This is lateral sulcus. This one is lateral sulcus, and pterion is here, right here. So beginning at the stem of the lateral sulcus, or what is called as the Sylvian sulcus, that is where pterion is. And what about the central sulcus, which they have mentioned? If you want to talk about central sulcus will be running anterior-inferiorly like this. This is central sulcus. So that is central sulcus, which separates frontal lobe from the parietal lobe. And that is not where we have the pterion. The question is asking about central sulcus. Where is central sulcus? This is central sulcus. And what central sulcus does? It separates frontal lobe from parietal lobe. But that is not where we have pterion. Then where is pterion? Pterion is right here at the stem of the lateral sulcus. And what the lateral sulcus on cerebrum does? It is separating the temporal lobe inferiorly, and superiorly it will be frontal and parietal. So that means choice C is also wrong. And instead of writing overlies the stem of central, they should have written lateral sulcus, which is also called Sylvian sulcus. This lateral sulcus has one more name, and that name is the Sylvian sulcus. Now, what about choice number D? So there comes one single chat, and the name is nothing. What kind of name is that? And sir, आप प्लेटफॉर्म पे नहीं हो अब. Doesn't matter. टीचर आपके पास हमेशा रहेंगे, इस प्लेटफॉर्म पे हो, उस प्लेटफॉर्म पे, किसी भी प्लेटफॉर्म पे. इस वक्त मैं डॉक्टर रॉयल्स पर हूं, और आप जो है जितना बेनिफिट उठा सकते हैं हमारी नॉलेज का, हमारे एक्सपीरियंस का उठाइए, अच्छे डॉक्टर बनिए. आप ठीक है, आपने वहां नथिंग लिख दिया, फिर यहाँ पे आएगा समथिंग, फिर यहाँ पे आएगा द ग्रेटेस्ट थिंग एवर. मेहनत करिए और आगे बढ़िए. ठीक है. So, and what about choice number D? It is also wrong. Why choice number D is wrong? Because a fracture in this area can lead to not subdural hematoma. It will be extradural or epidural hematoma. So what you get here is epidural hematoma or what is called as extradural hematoma, not the subdural. There'll be one artery running deep, that is anterior division of middle meningeal artery. Whatever I am telling, they are all MCQs and they have high chance of appearing again. Anterior division of middle meningeal artery that will bleed to give extradural hematoma or extradural hematoma, and that will be under pterion. So this is a wrong choice because it is not subdural. Subdural is because of some bridging veins and there are other reasons for that. Out of all these choices, everything is wrong except choice number B, because it is definitely formed at 3 to 6 months. So 3 months is fine according to Gray's anatomy. So let us proceed further. So joy has come now and giving 100%. Yes, in life we should always be giving our 100%. And joy is a good name. And I hope this nothing changes into something and changes into the greatest thing ever very soon. Okay, so moving on to next question. This is the next question which you have got. Tell me what is the answer. The questions which we have taken are from the recent topics, recent exams, and they have high chance of appearing again. And what you want is just cross the 50% barrier. Definitely you'll cross it, but to cross the 50% barrier, you must target for 75%. Target for 75%, you'll definitely get 60%, and 60% is good. But if you target for 50%, you know what happens with most of the people. Don't target for 50%. Raise your bar higher. Okay? Yeah, Joy? Yes, yes, yes. Definitely we'll be the winners. Okay? We need good doctors, sincere doctors, skillful doctors. There is deficiency and we need you people. You are the future. You are our future. So push it hard. Push to the maximum. Adrenalize yourself. What do you think? Skin receptor responsible for detecting the rapid vibration. Now they're asking rapid vibration. There can be slow vibrations also. Before I mark the answer, let me take you to this diagram, which you should be aware of. And we'll be putting some details now. As you will notice, we are looking at the skin receptors here. And when we are talking about skin receptors, you will start the very first, you can start here. See, in the skin, you will have skin epithelium, epidermis, and then down is dermis. Dermis is thicker and epidermis is thinner. In the epidermis also the basal layer. The basal layer of epidermis, you will have one receptor which has been magnified, and that is magnified here. And you can see that is called as Merkel receptor, Merkel cell Merkel receptor. Basal layer of the skin epithelium, epidermis, you have this receptor number 1. I'll be drawing a diagram, but just look at the region, location. Number 2, I'll be talking about is near to it. That will be the Meissner corpuscle. Meissner corpuscle is at the dermo-epidermal junction. At the dermo-epidermal junction, this is the Meissner corpuscle, number 2. Then number 3, I'll be talking about Pacinian corpuscle. This is the Pacinian. So number 3, we'll talk about Pacinian corpuscle. And number 4, we'll be talking about Ruffini receptor. Number 4, the Ruffini receptor. And once you have this orientation, that these two are in the deep dermis, basically. Let us draw the diagram. As you draw this diagram, you will see that we are basically talking about two things. One is epithelium, that is the skin epithelium, or you can say epidermis, and below that is the bigger region, that is dermis. Dermis also, there will be superficial dermis and deep dermis. So first you have epidermis, then below that is dermis, which is superficial and deep. Now here we are showing at the basal layer of the skin epithelium, the basement, near the basement membrane, is one cell, number 1, and we are calling it as Merkel cell. This is Merkel. And then Merkel cell, you remember, like I'm holding a pencil, it will give me the feeling, sensation of that. So it is light touch sensation. Merkel works for light touch sensation, and it will be giving me sustained light touch, sustained, because it is slowly adapting. It is slowly adapting. So it cannot give me immediate information because slowly adapting. So sustained touch should be there. Then it will be telling me about light touch. This is number 1. Now let us come to number 2. Number 2 is here. and as we are telling the name, it is Meissner corpuscle. Now, as we talk about Meissner corpuscle, it is at the dermo-epidermal junction, and it is also working for light touch, but it is rapidly adapting. So it is rapidly adapting, and it is Meissner corpuscle, and it has certain function. Like one thing it does is it'll take care of fine touch. Fine touch, that is why it is important for tactile discrimination, 2-point discrimination. In the patient's neuro ward, you do 2-point discrimination, tactile discrimination. This is a good receptor to carry 2-point discrimination. It is also working for touch, and it is rapidly adapting. And then you can also understand, the thing is, you have to be careful here when you say it will detect vibration. Not only it is for tactile discrimination, it is detecting the vibration also, but that vibration is not very fast, means some 50 hertz, maybe some 200 hertz, but it will be slow vibration, because for rapid vibration you have got here the onion skin appearance, that is the Pacinian. So Pacinian, which is in the deep dermis, this is number 3. Number 3, Pacinian in the deep dermis, and this is detecting P for P, pressure, P for P, Pacinian for pressure and vibration, but this vibration will be high. So rapid vibration, that was our question. Our question was, who will detect the rapid vibration? And that is Pacinian, because the Meissner, though it is rapidly adapting, but then it is detecting slow grade of vibration. Vibration means that frequency. So that frequency is less, then it will detect the Meissner. Otherwise, frequency is rapid vibration, then will be Pacinian. Then what about number 4? Number 4, as you will notice, we are showing here Ruffini receptor. This is Ruffini, and Ruffini is for the dermal stretch. Dermal stretch means like you are undergoing massage, and massage, dermal stretch, skin stretch. And be careful, this is slowly adapting. So now you have got 2 slowly adapting. Number 1, it was the Merkel, this is slowly adapting, and number 2, it is the Ruffini, which is slowly adapting. 2 slowly adapting and 2 rapidly adapting. What are the 2 rapidly adapting receptors? The Meissner is rapidly adapting and Pacinian is rapidly adapting. In that also, 2 of them are in the deep dermis, and 2 of them are, one is in the superficial dermis, one is in the epithelium itself. So these are the 4 names which we wanted to talk about. Let us come back to our question now. And as you are looking at the question, now you will be able to find your answer quickly. What do you think is the answer? Skin receptor, which is responsible for detecting rapid vibration. It will be a rapidly adapting receptor, but which one? Meissner or Pacinian? So it should be Pacinian corpuscle. Now, why did you take your answer as Pacinian? Why not Meissner? Because Meissner works for the slow, or the vibration should be of low frequency, slow frequency or low frequency vibration. Then it will be Meissner. What is the other function of Meissner? Meissner is basically for tactile discrimination, touch, like 2-point discrimination, and it is also detecting vibration, but that vibration should be slow, not the rapid. For rapid detection of vibration, we have Pacinian. Pacinian is the answer. And P for P, so it is P for P, it carries pressure as well as the vibration. And because it is deeply located in the dermis, it is in the deep dermis, so your pressure should be deep, deep pressure, deep vibration. That is why rapidly adapting. What about the Merkel? Merkel we have discussed earlier as well. Merkel, first of all, it is in the basal layer of epithelium, the last layer of epithelium, and it is for light touch sensation, and it is basically slowly adapting. It is slowly adapting, and it is not detecting the vibration at all. Means they can detect, all the receptor can detect everything, but we don't consider this as looking for vibration. It is for light touch sensation, like holding a pen. And what about the Ruffini? Ruffini is in the deep dermis. It is slow adapting. First of all, it is slow adapting. Second, it is in the deep dermis. And third thing, it is for stretch, like skin stretch while you are undergoing the massage. A lot of details are there, a lot of questions are there. They continue coming, but here we'll keep our answer as Pacinian corpuscle. So Joy, you have given the answer B. That is perfectly fine. Let us move on to the next question. Next question, as you see, is asking for the rotation of the midgut. So when we are talking about the developing gut tube, foregut, midgut, hindgut, it is the midgut which is more focused upon, though foregut is also rotating. Foregut rotates by 90 degree. Stomach rotates by 90 degrees. Stomach is foregut. So that is 90 degree. But chiefly we talk about midgut rotation. And what do you think midgut is rotating by how many degrees? To make you understand, let me first tell you that there will be a duodenojejunal junction and there will be one ileocecal junction, the DJ and IC. So there is a DJ, duodenojejunal junction, and there is IC, ileocecal junction, and they'll be developing in the baby. They go out of the baby. They herniate outside into umbilical cord, and then they start rotating. So proximal segment DJ, duodenojejunal junction, the distal segment IC, ileocecal junction, and then they rotate. As the gut is going outside into umbilical sac, which is called physiological umbilical hernia, it will rotate anti-clockwise by 90 degree. So first rotation is anti-clockwise by 90 degree. DJ will come here and IC will be here. So first rotation, first of all they go out and rotate. Then they'll try to come back. They are coming back because they cannot be there in the umbilical sac. They have to come back. So as they come back, now there'll be another 180 degree rotation, 90 degree and 90 degree. And when see, first of all it is 90 degree, then it is another 90, another 90. Now the DJ will come here and IC will come here. That will be the final position in the adult. So basically what we learned is, first we have physiological umbilical hernia. The midgut loop will move into the umbilical cord, and there it will be rotating anti-clockwise by 90 degree. Then it will come back. As it is coming back, it will be rotating again anti-clockwise by 180 degree. So what is the total? Total, it is anti-clockwise 270 degree. And which artery it is, because if you have DJ and IC, what is the axis on which they are rotating? That axis is the artery of the midgut. And which is the artery of the midgut? Artery of the midgut is superior mesenteric artery. So superior mesenteric artery is the artery of the midgut. That should be our answer, because it is the midgut which is rotating. What about inferior mesenteric artery? Inferior mesenteric artery is the artery of the hindgut. That is not rotating. Then what about middle colic artery? Middle colic artery is a branch of superior mesenteric artery. So it is a branch of superior mesenteric artery, but it is the superior mesenteric artery, that is choice A, along which the rotation is happening anti-clockwise. What about superior rectal? Superior rectal is a branch of inferior mesenteric artery supplying hindgut again, but hindgut is not rotating as such. It is foregut and midgut which is rotating. So we'll keep our answer as choice number A, and the details you can see which I told you are here. There are two diagrams which we need to know. So what is the first diagram showing? In first diagram you can see for yourself. Let us use this color. See, you're looking from side view. So as you talk about anterior abdominal wall, posterior abdominal wall, anterior abdominal wall, posterior abdominal wall, there'll be gut tube, and that gut tube, see, this is the anterior abdominal wall where you will have the umbilicus here. This is the anterior abdominal wall where you have the umbilicus, and midgut is going out. When midgut is going out, this is called as physiological umbilical hernia. Week number 6 of development it will happen. And why this midgut is going out? Because the baby is growing, but there is not enough space in the abdomen, so some part of gut will go out, and that is called physiological umbilical hernia to enter the umbilical cord. By week number 10 it should come back. So by week number 10 it will come back also. And when it is going out, what is the axis on which it is going out? That axis is superior mesenteric artery, the artery of the midgut. There are 3 gut and 3 arteries. So what is the foregut artery? Foregut artery is the celiac artery. Midgut artery is superior mesenteric artery. Hindgut artery is the inferior mesenteric artery. And they are all coming from abdominal aorta, which is on the posterior abdominal wall. So on the posterior abdominal wall, you are having the aorta, and that aorta is supplying the gut tube. This is foregut, midgut, and hindgut. And for the foregut, you have the celiac artery. For the midgut, you have superior mesenteric artery, and for the hindgut, you have the inferior mesenteric artery. But it is the superior mesenteric artery which is supplying the midgut and going outside along with midgut into the umbilical cord, and physiological umbilical hernia. It should come back. And what happens if it doesn't come back? Can you tell me? Can you tell me what will happen if midgut goes out and doesn't come back? What is that called? Joy? Nothing? Tell me, what is that situation called when the midgut has moved out and through umbilical cord and is not going back? It comes as a question. You call it as omphalocele. Omphalocele. So it is, omphalo is umbilicus, cele means hernia, kind of umbilical hernia. And why it happens? Non-regression of physiological umbilical hernia. When the hernia is not going back, it goes out and stays there, doesn't go back. That is called omphalocele. So all these are information. Yes, very good, fantastic, Joy. You are at least reaching 2 points, omphalocele gastroschisis, but it is omphalocele, correct. And Ajinkya has perfectly hit the target, omphalocele. Let me tell you about other details as well. But in this question, of course, your answer should remain. What should be the answer in this question? If it is the midgut they are asking, midgut loop, then you say it is superior mesenteric artery. Now, once you have given that information, let us go on to the next question. And it is asking that fetal midgut is rotating intrauterine life by how many degrees? So we already have described that fetal midgut, if we say, it is basically undergoing physiological umbilical hernia. The first thing is anti-clockwise 90 degree, and second thing is anti-clockwise 180 degree. So if you join anti-clockwise 270 degree, and that is what? 270 degree anti-clockwise. Your answer should be choice number C. Now, once you have, yes, very good, fantastic. Nishit, Ajinkya, Joy, all of you have answered choice number C, perfectly fine. And that is how, you keep practicing the topics, and ultimately, sometimes it happens like when you look at the question first, then you see, I don't know nothing. But just 5 minutes of going through the details, and you will never mark the wrong answer. And that is what, see, what is a doctor? Doctor is a human, and to err is human, but a doctor will make errors the least, because he is taking care of lives. The most important thing in this universe is human life, I believe. So even doctors can make mistake, but you have to keep minimizing your mistakes. That is the training for, isn't it? So as you see, I will not go into much detail here, but as you can see for yourself, as we were talking about DJ and IC, duodenal junction, ileocecal junction. So proximal limb, cranial limb is the DJ, duodenal junction, and distal limb is the IC, ileocecal junction. And this is where the artery will pull it outside. See, this is the DJ, and that is the IC. They are rotating as the angle is showing. So first rotation is shown here. This is the 90 degree, and then there'll be, it has come out, now it is going back. As it goes back, see, the ultimate purpose is the normal arrangement of gut in the body. So what is the normal arrangement? Normally, the ileocecal junction is not superior, is not inferior. This is ileocecal junction, it is not inferior. It is on the right iliac fossa. It is on the right iliac fossa. And where is the DJ? DJ is somewhere near the midline. Somewhere near the midline, the duodenal junction, slightly to the left side, will be here. So DJ is here, IC is here. But initially, where they were? Like this, DJ and IC. They are rotating 90, 90, 90. So the ileocecal junction comes to right iliac fossa, and duodenal junction comes to the central point almost to the left side. So this is how the gut is rotating. That is what we are showing. That is what is important for gastroenterology people, or surgeons who are working in this region. That will, like Dr. Raja Mahendran will tell you more about that. But as such, we'll keep our answer, as anti-clockwise to 70 degrees. Everything is important what the examiner is asking, because one day you'll find it important when you become the expert. If you go into surgery, if you go into gastroenterology, become a surgeon, then you will realize all this information is important. Now, the other question which you find in front of you is structure. So Ajinkya is asking anatomy since yes, right, Ajinkya, thank you very much. I thank you for all the appreciation. I try my best, and my purpose is that students should become comfortable with anatomy. Normally they are scared of anatomy. They should be comfortable. They should not fear anatomy, number one. Number two, to make it a little bit interesting so that you develop interest yourself. And number three, to make you a better doctor, skillful doctor, efficient doctor. Because whatever you become, maybe you become gastroenterology DM, or you become MCH surgeon, whatever you become, you should be very good with anatomy. That is the purpose. And some of the students will realize and they will work hard, because things are not easy. You have to work hard. You have to use your intelligence. God has given intelligence to everybody, and you have to make use of that intelligence. But intelligence doesn't work for long. You have to work hard also. So hard work plus intelligence. Okay, right. So yes, Harshita, Jikesh, C is the answer. You are perfectly right, as we are talking about the structure in the dorsal mesogastrium. Meso means it is mesentery. Mesentery means it is double fold of peritoneum. Double fold of peritoneum. Gastrium means it is stomach, though it is used for gut. So because it is related with stomach, so gastrium, otherwise gut. So double fold of peritoneum attaching to gut. But why do you need double fold of peritoneum attaching to gut? To carry neurovascular bundle. So you have to carry neurovascular bundle, and they will keep asking that which neurovascular bundle is present in this ligament, that ligament, nerve, artery, vein. So if you are talking about dorsal mesogastrium, yes, you are correct that your answer is linorenal, or what is called as splenorenal, because it is between spleen and the kidney. Splenorenal ligament, it is dorsal. What about lesser momentum falciform? They are ventral. And what about lever? Lever develop in ventral mesentery. So as we proceed further, you will see we are talking about this diagram only. And in this diagram, you have to understand that there are, see, this is a side view. You are looking from side view like this, and anterior abdominal wall and posterior abdominal wall. From anterior to posterior abdominal wall, there is a double fold of peritoneum, and that double fold of peritoneum is carrying some nerves, artery, and veins, lymphatics also. So that double fold of peritoneum is given some names as the baby develops. What happens is that the gut tube becomes the axis. Say this is the foregut here, this is the foregut, this is the midgut, and that is the hindgut. Foregut, midgut, hindgut, and that becomes the axis. The peritoneum which is in front of that, especially the stomach, we call it as ventral mesogastrium. So this will be the ventral mesogastrium. As you can see, this area is ventral mesogastrium because it is ventral to the stomach or the gut tube. And then there will be a dorsal mesogastrium. So which is behind that will be a dorsal mesogastrium. And as you can see, the aorta is giving branches, and those branches will be carried by double fold of peritoneum to various organs. Now, one organ is developing, which is developing in the ventral mesentery. So what is developing in ventral mesentery is liver. Liver develops in the ventral mesentery, whereas spleen is developing in the dorsal mesentery. And along with spleen, two ligaments will develop. So which ligaments will develop, you can see for yourself. With the stomach, it will be having the splenogastric ligament. Splenogastric ligament with the stomach. This is the gut tube, foregut, the stomach. And behind, you'll find in the posterior abdominal wall, there is kidney. Kidney will be there. So related with kidney posteriorly, and that will be called as the splenorenal ligament or the linorenal ligament. That is what the question is. So which ligaments develop in the dorsal mesentery, or which organ develop in the dorsal mesentery? In the dorsal mesentery, we have spleen, and its two ligaments are also developing. Name splenorenal and splenogastric, both of them in dorsal mesentery. What about the ventral mesentery? In ventral mesentery, we'll have some ligaments like the one which attaches to anterior abdominal wall is falciform ligament. Here we'll have what is called as the falciform ligament, and attaching lever to the anterior abdominal wall. And then there'll be one ligament which is attaching the lever to the stomach and first part of duodenum. Now that ligament which is attaching the stomach with the lever and also first part of duodenum, it is attaching to the lesser curvature of stomach, and it is called as lesser omentum. So that is where we'll have the lesser curvature. This is lesser curvature on the posterior side. This is greater curvature. So lesser curvature, what is attaching is lesser omentum. Other name, you can see the stomach and liver. So hepatogastric ligament or hepatoduodenal ligament. So there are two of them, hepatoduodenal, hepatogastric. If you combine them, you will see it is called as lesser omentum. Lesser omentum or falciform, both of them develop in ventral mesentery with the lever, whereas spleen, both the ligaments, splenogastric or splenorenal, develop in the dorsal mesentery. So this is the basic we need so that we can answer the question here. We already have answered the question, in fact, and we are being asked that what is developing in the dorsal. In the dorsal mesentery, we have spleen, and along with spleen, we have two ligaments, named splenogastric ligament and splenorenal ligament. And splenorenal is the other name, splenorenal. That is why choice C is the answer. What about the ventral mesentery? In the ventral mesentery, we have lever, and along with lever, what are the ligaments? Lesser omentum and then falciform ligament. So lesser omentum and falciform ligament, if you look at them, both of them will be developing in the ventral mesentery with lever. And what about lever? Lever, of course, ventral mesentery. So others, they are in ventral mesentery. Only one is in the dorsal mesentery, and that you already have answered. Sonu Parvar sir. Thank you very much, Dr. Sonu. Very modest person, hardworking, trying to help students as much as possible. I have been friends. I have known Dr. Sonu for quite long. A great human. Though you may not be coming in that exposure, that kind of exposure, because he will be opening up with me more than students, but very nice human. And see, the point is, what is your role in the society? That is more important. What are you doing? What are you doing in this society? That is more important, because everybody lives, everybody takes care of themselves, take care of their family. But are you working, doing something extra, coming out of your comfort zone and trying to improve the life for other people? And it is not easy. You have to struggle. You have to be competitive. You have to struggle, and you have to take a lot of pain, efforts, and still people will not say good things about you. So that all comes with you, but you should justify your stand. If you are in a field, you should be the best in your field. That's what. And I'm talking about you people, students. Dr. Sonu has already achieved that, and he doesn't stop there. He is still working upon that. I am still working upon that. Everybody is still, see, whoever have tasted success will try for more and make life better for other people. You can always make life better for yourself, but try to make life better for your parents, your siblings, your family, your society, your Andhra Pradesh, Tamil Nadu, Malayalam, Kerala, Delhi, India, Pakistan, Russia, Earth, solar system. Nowadays, people talk about going to Mars. So why not? Yes, Joy. Yes, it is. Joy, your name is good. That gives you positive feeling. And that is what we should be having. Most of the time, we should be having positive feeling. So this question is asking us about which of the following is the primary lymphoid organ. So when you say about primary, there'll be a secondary also. What is the difference? The chief difference between primary and secondary lymphoid organ means they'll have lymphocytes. The B lymphocyte and T lymphocyte. We were talking about Sonu, Dr. Sonu, and Dr. Sonu, the topic has come immunology. So B lymphocyte and T lymphocyte, and these are lymphoid organs. Now, what is the difference between primary and secondary? Primary lymphoid organs will have stem cells and they'll be involved in lymphopoiesis. Lymphopoiesis means they will be making the lymphocytes. Basically, maturation occurs, formation and maturation occurs in the primary lymphoid organ. I'll repeat. What is the difference between primary and secondary? Primary lymphoid organ will have stem cells, secondary will not have. Secondary lymph organ, they don't have stem cells. So only primary can make lymphocytes. Now primary, they have stem cells, they are involved in lymphopoiesis and they are for maturation. Then what is secondary for? Secondary is basically for mounting the immune response. Means they will detect the antigen and will mount the immune response. There are two M's. One M is maturation, that is in primary. The other M is mounting the response, immune response, that is in the secondary. So I think you already would be knowing the answer. You already have answered. Nishit, Harshita, Joy, you are giving your answer as C and you're perfectly all right. Thymus is definitely the... Can you tell me one more thing about thymus? Thymus is a special organ where you do not have, it is a reticular tissue. First of all, we should know that they belong to reticulum. They have reticulum because the lymphocytes are to be suspended. So the lymphocytes need to be suspended in reticulum, and normally lymphoid organs will have type 3 collagen fibers. So type 3 collagen fibers will be there because type 3 collagen fibers will be forming the reticular fibers, and these reticular fibers will be helping us to suspend the lymphocyte. Now my point is, when type 3 collagen fibers are there in the lymphoid organs, and in the lymphoid organs you need reticular fibers to suspend the lymphocyte. If thymus is not having the reticular fibers, what is it having? How will it suspend the lymphocyte? So normally we should know that type 3 collagen fibers make the reticular fibers to suspend lymphocyte. This is present in lymphoid organs. Whatever lymphoid organs you may talk about, maybe spleen you are talking about, or maybe you are talking about lymph node, or you are talking about the others like tonsil maybe. So these are the organs where you will have the reticular fibers, but thymus doesn't have it. So what does thymus have? How do you suspend the lymphocyte? And thymus is special. It has no reticular fibers. It has thymic epithelial reticular cells. Thymic epithelial reticular cells. So all of these are MCQs which have come frequently and they have high chances of repeating themselves. So thymus do not have reticular fibers. It has thymic epithelial reticular cells. Now, what about the other names which are given here? You can see here in this diagram now, as we are telling, what is the difference between primary and secondary? So as you see, the primary lymphoid organs, they will have stem cells, and those stem cells can make lymphocytes. Who is making the lymphocyte? Lymphocyte is made by bone marrow. Remember that. So bone marrow will make the lymphocyte. Now, when the bone marrow was making lymphocyte, it was making two type of lymphocyte. That is the B lymphocyte and T lymphocyte. And the B lymphocyte will be undergoing maturation in the bone marrow only. You can remember B for B lymphocyte and bone marrow. So the bone marrow will make the B and T lymphocyte, both of them, but the B lymphocyte will be matured in the bone marrow, whereas the T lymphocyte will be given to thymus. It will be circulated towards the thymus. So remember T for T lymphocyte is trained or matured by thymus. So maturation happens in thymus. I'll repeat once again. Both of them are primary lymphoid organs. Why? Why bone marrow and thymus are primary lymphoid organs? Because they have stem cells. Secondary lymphoid organs, they do not have stem cells. So that is different. So if they have primary lymphoid organs have stem cells, what they do? They form lymphocytes. Like the red bone marrow has formed B and T lymphocyte, and T lymphocyte will go to thymus. T for T, thymus trained lymphocyte. Maturation of lymphocyte, T lymphocyte happens in thymus, and maturation of B lymphocyte happens in bone marrow. Now what will happen? What will happen is the B lymphocyte in the bone will change into plasma cell, and plasma cell will make the antibody, and you will have humoral immunity. So humoral immunity, which is antibody mediated immunity, that is by the B lymphocyte. In the red bone marrow, you made B lymphocyte. B lymphocyte became plasma cell. Plasma cell form antibodies. Antibody mediated immunity or humoral immunity, that is there. What about the T lymphocyte? T lymphocyte was migrating to thymus, and there it will be trained for cell mediated immunity. So there you will have cell mediated immunity, and that is the T lymphocyte thymus related. Now these B and T lymphocyte, they'll move to the periphery. As they move to the periphery, there they can mount the immune response. So mounting immune response where? Lymph node throughout the body, tonsils like palatine tonsil, tubal tonsil. Then you have spleen. Then you have MALT, actually mucosa associated lymphocyte tissue. So mucosa associated lymphocyte tissue, like in the terminal ileum, you can have pair patches. In the terminal ileum, you can have pair patches. Pair patches are basically the mucosa associated lymphocyte tissue, or even in the appendix, vermiform appendix. In the vermiform appendix, as you see, in the vermiform appendix, you can have the MALT, mucosa associated lymphocyte tissue. So what are these? These are all secondary. Why would you say secondary? Because none of them will have stem cell. I told you there is one M for the primary, that is the maturation, and there is one M for secondary, that is mounting the immune response. So as you come back, you will see in this question we already have answered, and the answer was thymus, because it is primary lymphoid organ. If you say lymph node, spleen, or liver actually is not a lymphoid organ. Liver is not a lymphoid organ at all. You cannot classify liver as lymphoid organ. It is not a lymphoid organ as such, though it will have, say Kupffer cell for mounting the immune response, but Kupffer cell came from the bone marrow. They are resident macrophages, but they came from bone marrow. So lymphoid or liver, you cannot classify it as lymphoid organ. Primary, secondary is next. First of all, it is not a lymphoid organ at all. So we'll keep our answer as choice number C here. Now, as we move further, you see this question. It is asking which part of the placenta is attaching to the maternal side. So what do you think? When you talk about the placenta, you'll have two components. See, this is about placenta. Placenta will have two components, maternal and fetal. So mother will give some component. In the mother, the baby is attaching to endometrium. So it will be functional endometrium. And what is the name of that functional endometrium? It is called as decidua basalis. Decidua basalis. So it is the functional endometrium which the mother will give for placenta. What about the fetus? Fetus is having some membranes, and it will form what is called as chorion frondosum. Chorion frondosum is the component what the baby will give. Say, let us look at a uterus here. So this is the uterus, and in the uterus you are having the baby. In the uterus, let us say that this is the endometrium. That is the endometrium in the uterus. Now, if you tell that this is the endometrium in the uterus, it is that endometrium which will be giving us the decidua basalis. So here, decidua basalis, that is from the mother side, maternal side. Now, what about the baby? Now the baby has come, and baby is attaching here. This is the baby. Now when the baby comes, baby will also give you some component of placenta. What is that component called? The baby, what it gives is called as the chorion frondosum. There will be some finger-like processes, chorionic villi, chorionic frondosum will be given by the baby, and together they will be forming the placenta. So what is the answer then? As you see, which part of placenta is attached to the maternal side? To the maternal side. Maternal side, if you say placenta component, is decidua basalis. So that is choice number B. What about the decidua parietalis then? Parietalis means periphery, and basalis at the base. And what is capsularis? Capsule is something which covers. So what about chorionic plate? Chorionic plate will be on the fetal side. So chorionic plate will be towards the fetal side. But anyway, in this question, the answer should be choice number B, because they're asking for maternal attachment. and this is some diagram which we were talking about. You can see in this diagram that this is the baby, maternal side is here. So this is the maternal side we were talking about, and the placenta is decidua bacillus from maternal side. This is maternal placenta. Now that is the maternal placenta. You know, endometrium is covering the baby also, and there is some endometrium which is away from baby. So endometrium which is away from baby is decidua parietalis. It is not related with the baby, so it is decidua parietalis periphery. Then what about decidua capsularis? Capsularis is not contributing to the placenta. It is not. It is like a capsule around the baby. It is like a capsule around the baby, capsularis, but it is not contributing to placenta. That means neither capsularis nor parietalis, they are contributing to placenta. Who's contributing to placenta is the something at the base, decidua bacillus. And what about the baby? The baby was developing trophoblast. Trophoblast will form the villi, primary, secondary, tertiary villi, chorionic villi. And in that process, as the baby is forming those finger-like processes, villi, they are going to contribute this thing. And what is that? That is the chorion frondosum. And that is the fetal placenta. And that fetal placenta will then communicate with the maternal placenta. And what is the maternal placenta? Maternal placenta we already have mentioned, decidua bacillus. So number one, decidua bacillus, and number two, chorion frondosum. That is exactly what we have as placenta. Otherwise, this is decidua capsularis, and that is decidua parietalis. So if you see here, this will be decidua parietalis, and that will be decidua capsularis, and none of them contribute to placenta. Okay, so Shivani and Harshita, you already have given the answer as B, and B is the answer, decidua bacillus. No issues here at all. Now, as we proceed further, you will see this is another question asking which congenital anomaly where you have the intestinal loops present outside abdominal cavity covered by amniotic membrane. We have just discussed this in a short while ago. What do you think is the answer? Was there mistakes in today's answer? Which question? G unlimited. Which question? Which question? Yes, I think Shivani already have answered perfectly fine. Nishit, perfectly fine. Harshita, perfectly fine. G unlimited, you have to tell me which question are you asking about? Because normally there won't be any mistakes in the questions which I prepare myself. There is one clerical error in the question, not the answer. Answers are perfectly fine. But there is one clerical error, and I'll mention it is almost the last question where there is some clerical error. Question behind. Okay, so you are asking about this question. So, okay, G unlimited. So the question is which part of the placenta is attached to maternal side, and I'm telling decidua bacillus. So do you have a difference of opinion? Yeah, G unlimited. Yes, 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 perfectly fine. You caught the question. That is the question I'm talking about. There's a clerical error in the question. When we were writing the stem, in the stem there is a term used except, and that should not be there. Perfectly fine. G unlimited. You have spotted the mistake. In 20 questions, there were no mistakes. Actually, there are no mistakes in answer, but there is a framing problem in the question. You have got it. And yes, I'll discuss that. Already I have spotted that. See, to err is human, and I'm a human. I'll make errors, but I'll minimize my errors. You will minimize your errors. We are not God. We cannot be God. And even God makes error. So we do make error, but we should minimize our errors. In these 20 MCQs, I made it sure that there should not be any mistake, but still there was a mistake which I already spotted, and G unlimited has already spotted the same. So we'll talk about that. There is just a clerical error, in fact. Yes, G unlimited, I appreciate your focus, and To find mistake in somebody who is claiming that he doesn't make mistake is a great achievement. When I started telling my students and my colleagues that there is mistake in Gray's Anatomy, they used to look at me like, what? Now you have become so proud that you are telling that there are mistakes in Gray's Anatomy. But there are mistakes in Gray's Anatomy also. And why? Because we are humans. We are going to make mistakes. But we have to minimize the mistakes. In your FMGE exam also, what are you supposed to do? You have to minimize your mistakes, and FMG will be clear. Then after that, PG will be clear. You will become MDMS, and after that, you'll become DM, MCH, and by the age of 40, not to dishearten you, but by the age of 40, maybe you will be a great, successful doctor. And that the name which was in the beginning nothing would have become something, and by the age of 50 he would have become, he or she, I don't know whether he's a he or she, but something from something, a very great thing. Okay, we'll be talking about other things, but let us proceed further. And okay, so these are some questions which the examiner is persistently asking, and we have to identify them first. You see, the very first diagram which we see here, this one, is, you see, this is the male, testicles are evident. This is the anus. Then you see bifid pubis symphysis is bifid pubis symphysis. The two ureters and urethra opening is evident. The two ureter and urethra opening is evident. That means trigone is evident. That means urinary bladder posterior wall is evident. So urinary bladder posterior wall is evident because anterior wall is open. Urinary bladder anterior wall is open. Posterior wall trigone is evident. Ureter is evident. Urine is coming out. This is called as ectopia vesicae. So this is a case of ectopia vesicae, or you can also call it as the exostrophy. Exotrophy is good. So extrophy of urinary bladder. And why it happens? Because lateral folding is not complete. During development, there is a lateral folding. So lateral folding will close it. But if lateral folding is not closing, then it will be open. So what will be open? Urinary bladder is open, pubis symphysis is open, all these things, the pubic bones will be apart. So that is bladder extrophy or ectopia vesicae. What is this? It is gastroschisis. How do you identify it is gastroschisis? Because gastroschisis comes to the right side of umbilicus. It is to the right side of umbilicus. Umbilical cord is normal. So umbilical cord is normal. There is intestinal herniation. On the right side of umbilicus. This is called gastroschisis. It is not covered by amnion. So gastroschisis, normal umbilical cord, to the right side of umbilicus, some intestinal hernia, not covered by amnion. If it is covered by amnion and in the midline, if it was covered by amnion and in the midline may contain liver also. So this time this is omphalocele. Omphalocele, umbilical hernia, kind of umbilical hernia. Omphalocele, umbilical hernia, kind of umbilical hernia, where even the liver can be inside the content along with the intestine, and it is inside the umbilical cord. Umbilical cord is not normal. So umbilical cord is not normal. Inside the umbilical cord, you have the liver intestine, and it is covered by amnion. So all of these are MCQs, and they have high chance of repeating themselves. And why this happened? Because I told you, physiological umbilical hernia, week 6, week 10, it should go back. And if it doesn't go back, then it will remain outside, and that is called omphalocele. Why do you have omphalocele? I have omphalocele because of the non-regression of physiological umbilical hernia. Non-regression of physiological umbilical hernia. It should go back. If it stays there, omphalocele. And what is this? This is actually persisting vitello-intestinal duct. This is the persisting vitello-intestinal duct, and normally it should regress. This is Meckel's anomaly, and Meckel's anomaly could be Meckel's diverticulum, Meckel's cyst, Meckel sinus. So Meckel cyst, Meckel sinus, Meckel diverticulum. It is persisting vitello-intestinal duct, and it has a rule of 2 to 2. Dr. Raja Mahendran will tell you that it will be 2 inches long, 2 feet from ileocecal valve, and it will be present in 2% population. So rule of 2. Your eyes should be able to identify the anomaly. And what is this? Here there is a weeping umbilicus, urine is coming out. So weeping umbilicus, urine is coming out, and why? Because from the apex of urinary bladder there is a communication. It is persisting urachus or lumen of the urachus. Normally it should be obliterated. So if the lumen of the urachus is persisting, urine from the apex of urinary bladder will come to the umbilicus, weeping umbilicus, urine coming out, and this is called as urachal fistula, urachal cyst, urachal sinus. So urachal cyst, urachal sinus, urachal fistula. This is hindgut diverticulum, allantois. It is a problem of hindgut diverticulum, which is allantois. So allantois is hindgut diverticulum, and if it is not, see, normally allantois, the hindgut diverticulum changes to urachus and obliterated lumen. But if the lumen is not obliterated, then you will have urine coming out to umbilicus, weeping umbilicus. So all these things are important. Okay, so Shivani, you were talking about ulnar nerve. We'll come to ulnar nerve discussion. Bladder extrophy, Shivani, fine, very effective because it is fastest revision. I don't know whether it is fastest. I always become very, very slow, and students tell you are spending so much of time, but maybe this will help you. Anterior wall of bladder is absent, ectopia vesica, no covering, amnion, chorion. Okay, yeah, interception. Interception means this gastroschisis can result in volvulus. The gastroschisis is prone to volvulus. All these are MCQs. Okay, so as we see this, already we have answered that if intestinal loops are present outside the abdominal cavity and lined by amniotic membrane, then it will be omphalocele. If it is not lined by amnion, maybe it goes in favor of gastroschisis. In gastroschisis, we do not have the lining of no amnion covering in gastroschisis. Okay, and Meckel's diverticulum, I have told you the rule of 2 to 2. And then umbilical hernia is very rarely seen. Umbilical hernia is simply some intestinal or omentum has come out in the umbilicus, and it will self-heal by itself. So it is not a big issue as such. But the first 3 are important congenital anomalies. We'll keep our answer as choice number B here. Now, as we proceed further, you look at this question asking what is the derivative of ultimobranchial body. For this, we have to understand that when we are talking about development, there are some pouches developing, and let me draw the pouches. Pouch 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Now you will say, why you are drawing pouch number 5? There is no pouch number 5. But there is a description of pharyngeal pouch number 5, though it will regress. And when the pharyngeal pouch 5 in the lateral wall of pharynx, developing pharynx lateral wall, you have 5 pharyngeal pouches. The 5th one is disappearing. And when the 5th one is disappearing, it will change into what is called ultimobranchial body. And that ultimobranchial body will be attaching ventrally here and to the pharyngeal pouch 4. So remember, there are 5 pharyngeal pouches. Pharyngeal pouch 5 is rudimentary, and it will become ultimate branchial body. Pharyngeal pouch 5 will be rudimentary, and remnant is ultimate branchial body. Ultimate branchial body then attaches to ventral aspect of pharyngeal pouch 4. And when the ultimate branchial body attaches to ventral portion of pharyngeal pouch 4, it will be populated by neural crest cells. As it is populated by neural crest cells, those neural crest cells, they will change into parafollicular C cell, and they will give the C hormone, that is the calcitonin hormone. So I'll repeat, pharyngeal pouch 5 becomes rudimentary, becomes ultimate branchial body, attaches to ventral aspect of pharyngeal pouch 4, is populated by neural crest cells. Those neural crest cells will change into parafollicular C cell, give the C hormone, calcitonin. So what is calcitonin doing? Calcitonin the purpose of calcitonin hormone is reduce blood calcium. But how will you reduce blood calcium? I will reduce blood calcium by two methods. What are the two methods of reducing blood calcium? Number one, I'll tell the osteoclast to stop. Stop osteoclast. Don't remove the bone calcium. So the calcitonin will cause reduced blood calcium by two things. Number one, it'll tell the osteoclast stop. Don't work for bone resorption. Let the calcium be in the bone. So bones will have more of calcium and less of calcium in the blood. Number two, it'll ask the kidney. It'll ask the kidney to start excreting the calcium. So just remove the calcium. Remove calcium. Just remove calcium. So if you ask the kidney to remove calcium, and if you ask the osteoclast, don't remove the calcium from the bone, obviously you will result in. So it is calcium metabolism, and it is working against parathyroid hormone. It has to maintain homeostasis. To maintain homeostasis means agonist, antagonist kind of thing. So it is working antagonistically with the parathyroid hormone for calcium metabolism. That is the purpose. Now, with all that information, and maybe you will think that this is a single question. We are spending so much of time on a single question. It is not single question. Some 4 or 5 questions already taken care of. So that is how you should prepare for your exams. When you look at one MCQ, you should take care of 4 or 5 questions related to that. Anyhow, so what do you think? Which of the following is the derivative of ultimate Brinkel body? If you are talking about ultimate Brinkel body, which is the remnant of pharyngeal pouch 5, then obviously you know what is your answer. Your answer is parafollicular C cells. A question comes, parafollicular C cells are derived from, and you should say parafollicular C cells are derived from the neural crest cells. Then what about the thyroid? Thyroid gland is endoderm, and it is endoderm at the junction of arch 1 and arch 2. So arch 1 and arch 2, at the junction you will have tongue developing, and in the tongue you will have foramen cecum, and in the foramen cecum you will have the thyroid gland developing. Thyroid gland develop from endoderm at foramen cecum in the developing tongue at the junction of arch number 1, arch number 2. I'll show you a diagram. Thyroid develop from endoderm at the junction of arch 1, 2, and it is at the foramen cecum. A diagram is coming up. What about capsule of thyroid? Be careful. Be careful about the capsule of thyroid, because capsule of thyroid is connective tissue, and connective tissue in the head neck region, especially anterior lateral connective tissue in the head neck region is from neural crest cells. Neural crest cell derived secondary mesoderm. I'll repeat my information. Be careful. This question has already come. Not for FMGE, it is for PG. For PG entrance exam, it has come. But be careful. Your questions are swapped from PG entrance also. So remember, maybe thyroid is endodermal, but not the capsule. Thyroid is endodermal, not the capsule. Capsule of thyroid is connective tissue. Connective tissue is neural crest cell derived secondary mesoderm. Be careful about that. What about the second branchial pouch? Second branchial pouch has nothing to do with the ultimate branchial body, because it is related with the fourth pouch and ventral. If fourth pouch ventral, then what is fourth pouch dorsal? What is fourth pouch dorsal? What will come from dorsal side? Can you tell me? Can you tell me in the chat? Remnant fifth pouch. So GL limited. If question says parafollicular C cells come from, and option has both neural crest cell and TB, then you will say neural crest cells. Then you will say, okay, now question is GL limited. You have asked a question, and that is a controversial question. It is asking that parafollicular C cells are coming from. Very first answer, neural crest cell, not given. Then you say ventral pharyngeal pouch 4, not given. Then you say ultimate branchial body, not given. Then you say pharyngeal pouch 5. I'll give you a sequence of answering the question, because it is a controversial question. Be careful here. If a question comes like GL limited has already asked, where is parafollicular C cell coming from? What is the first answer? First answer, neural crest cell, not found. Second answer, ventral part of pharyngeal pouch 4, not given. Third answer, ultimate branchial body, not given. Fourth answer, pharyngeal pouch number 5. And why it is like that? Because long back, somebody told us that parafollicular C cell come from pouch 5. Then later research was done and they told that pharyngeal pouch 5 disappears, it is ultimate branchial body which gives the parafollicular C cells. Sometime later, more research, and they found that it is not ultimate branchial body here, it is ventral part of fourth pouch. Then latest now we know that it is from neural crest cell. So first answer, latest answer, older answer, still older answer, oldest answer. But you should know all the answer. You should know your history so that you don't make mistake in present. You should know your history so that you don't make mistakes in your present. Formation of pouches. Yeah, that is what we are telling, Shivani. We are talking about the pouches only. If you want more details, let me tell you. Say pharyngeal pouch number. See, pharynx is developing. Pharynx is lined by endoderm. Lateral wall of pharynx will have pharyngeal pouches. Pouch number 1, 2, 3, 4, 5. Pouch number 1, if you focus upon pouch number 1, pharyngeal pouch number 1 will give you middle ear cavity and eustachian tube, which will open into pharynx. So pharyngeal pouch 1 on this side, both side, pharyngeal pouch 1 will give a middle ear cavity and eustachian tube, which opens into pharynx, nasopharynx, pouch 1. Pouch 2 will give tonsillar epithelium. Pouch 2 will give tonsil epithelium, not the tonsil, not the tonsil. It will give tonsillar epithelium, pouch 2. Pouch 2 will give tonsillar epithelium. And what about the pouch number 3? Pouch number 3, remember a mnemonic. Remember a mnemonic. Your mnemonic is, let me use some color which is not there. The third pouch, PP3 tip. Remember PP3 tip. Now what is this PP3 tip? Pharyngeal pouch 3. Yeah, but pharyngeal pouch 3, what is this tip? T for thymus and I for inferior parathyroid. Thymus and inferior parathyroid. Thymus and inferior parathyroid. So pharyngeal pouch 3, PP3 tip. What is PP3 tip? Pharyngeal pouch 3 will give tip. What is tip? The thymus and inferior parathyroid. If inferior parathyroid come from pouch 3, then obviously I asked you a question and you got your answer. I asked you, what is coming from dorsal aspect of pouch 4? What is coming from dorsal aspect of pouch 4? This question mark. And it is none other than superior parathyroid. That will be superior parathyroid. So here comes superior parathyroid. Superior parathyroid. So superior parathyroid is coming from pouch 4, whereas inferior parathyroid is coming from pouch 3. And this all will become clear. This all will become clear when you look at this diagram. So this is about the pharyngeal pouches. You can see for yourself now. Let me repeat. See, the pouch 1 is forming middle ear cavity and eustachian tube. Pouch 1 forming middle ear cavity and eustachian tube. This is pouch 1. Then what is pouch 2 forming? Pouch 2 will form tonsil epithelium. Pouch 2 will form tonsil epithelium. And what is pouch 3 forming? PP3 tip. PP3 tip means it is this one and thymus. And thymus. So thymus. So this is PP3 tip. And what about pharyngeal pouch 4? Pharyngeal pouch 4, as we have described already, it will be forming the superior parathyroid. But pharyngeal pouch 4, there will be something attaching ventral. And what is attaching ventral is called ultimate branchial body, which is an element of pharyngeal pouch 5, which will be populated by neural crest cell. So this is the pouch number 5 remnant, ultimate branchial body attaching to pouch 4. Pouch 4 itself is giving superior parathyroid. This is fourth pouch, PP4. This is PP3. These are PP3. And that was PP2. And that is PP1. This one and this one, PP1, pharyngeal pouch 1. Now look at foramen cecum. At the floor of pharynx, you will have tongue developing. And there is foramen cecum. Foramen cecum is the boundary line of which arches? Comes as a question. It is arch number 1 and arch number 2. So between arch 1 and arch 2, you will have foramen cecum, tongue developing. And the endoderm at the foramen cecum will come from here to here. Thyroglossal duct. Thyroglossal duct. So arch 1, arch 2, and in between you'll have thyroglossal duct forming thyroid gland. Thyroid gland is from the endoderm of foramen cecum at the junction of first and second arch. All that is important. This is the thyroid gland. It is endodermal in origin. Okay, right. Okay, so we are moving further now, and you look at this question. Auricle developed from. What is your answer? Auricle is the external ear. It will develop from 6 mesenchymal hillocks, 6 auricular hillocks, and these 6 hillocks, where they themselves come from. Before you answer the question, look at this diagram. You're looking from the side view, and as you look from the side view, you'll find that we are looking at arch number 1 contributing to 1, 2, 3 auricular hillocks. These are called auricle. So auricular hillocks. From the first arch, you have 1, 2, 3, and then from the second arch, you will have 4, 5, 6. So this is from the second arch now. So arch number 1 and arch number 2, arch number 2 and arch number 1. That will be your answer. Now the other thing is, okay, you have got arch 1, arch 2 giving 6 auricular hillocks, and the auricle is formed, but who will form the tragus? Tragus, which arch forms the tragus? Remember, the tragus is formed by first arch. Now if you say the tragus is formed by the first arch, if the tragus is formed by the first arch or the first auricular hillock, what about the ear lobule? Ear lobule, who is forming the ear lobule? And remember, ear lobule is from the second arch. It is from the second arch. So this is from the second arch. So just remember, there is arch number 1, 2, they will merge actually. And if you say tragus, this is first arch, and if you say ear lobule, then this is second arch. That should suffice. Otherwise, it is a controversial topic. ENT books will mention differently, anatomy books will mention differently, but both of them mention something same, which I just told you. So if you look at this question, it is asking that the auricle is developing from, and you should say the auricle is developing from first and second branchial arch. First arch giving 3 auricular hillocks, 1, 2, 3, and second arch giving the next 4, 5, 6. And then you can also mention 6 will form the ear lobule, and 1 will form the tragus of the auricle, like that. So you have given your answer D, perfectly fine, Shivani. G unlimited, yes, perfectly fine. And then we can proceed further. As we are proceeding further, you will notice that this is the question asking. Now, I think some of you must have answered it. Tell me what is the answer. Which nerve damage result in winging of scapula? You all will be searching for a name, but that name is not there. So first answer is not there. Second answer, be always ready for second answer. Sometime they will ask you drug of choice, but the drug of choice will not be available. So you should know who is second in line. So you should know who is second answer and who is third answer also. There are 3 answers. Winging of scapula can be due to 3 nerve lesions. So tell me what is the answer. Can you tell me? Shivani, G unlimited. B. Yes, perfectly fine. But do you know why this is the answer? So let us see. The thing is, whenever you attempt one MCQ, always ask, what is the answer? What is the answer? And then ask why that is the answer. And then ask why others are not the answer. And ask when they will become the answer. That is how you do MCQ. MCQ, how do you do it? Each MCQ you have to ask yourself, what is the answer? Why that is the answer? Why others are not the answers? When they will become the answer? That is how you deal with it. Okay, so you are telling that spinal axillary nerve is the answer. Perfectly fine. You should have been looking for long thoracic nerve which supplies serratus anterior. If you damage long thoracic nerve, then serratus anterior will be compromised and there will be winging of scapula. But that winging of scapula is called as medial winging of scapula. And the one which you are right now talking about is called lateral winging of scapula. So what is the difference between lateral winging of scapula and medial winging of scapula? See, when such a question comes, you should always look for which answer? Long thoracic nerve to serratus anterior. Because if serratus anterior is compromised, you will have winging of scapula. And that is called medial winging of scapula. But if that option is not available, what should I do? Go for the second answer. And who is the second answer? Second answer is spinal axillary nerve. Why? What will happen if spinal axillary nerve is damaged? Say, for example, you have a lymph node and you are doing incision and drainage. In the posterior triangle. In the posterior triangle, there's a lymph node, and you are trying to incise and drain, and you have damaged the spinal axillary nerve. If you damage the spinal axillary nerve, which muscle will be compromised? The next one, trapezius. And if trapezius is compromised, then what will happen? If trapezius is compromised, then you'll find difficulty shrugging the shoulder, and there'll be drooping of shoulder, and there'll be winging of scapula. Which winging of scapula will be there? So let us look at the details now. This is the midline of the body. You're looking from posterior side, from here. You're looking from posterior side. So this is the right scapula, posterior view. Looking from posterior, this is midline, that is right scapula, this scapula. Now remember, the scapula will have a muscle attaching anteriorly on the medial border. So on the scapula, medial border, but on the anterior side, not posterior, on the anterior side, name is serratus anterior. And serratus anterior pull the scapula like this. It is called protraction of scapula. Protraction of scapula. So that is the jaw of serratus anterior supplied by long thoracic nerve of bell. Long thoracic nerve of bell, because when you ring a bell, you use serratus anterior. So how do I ring a bell? You do protraction of scapula. Protraction of scapula. Pull the scapula forward. So serratus anterior, which attaches to medial border of the scapula, will pull the scapula forward. Yes. Push the wall. Push the wall. That is what you are doing, moving serratus anterior. That is protraction. Who will bring it back? Who will do retraction? If you're talking about retraction, then retraction will be done by several muscles. One of that is trapezius. So trapezius is a muscle which will be attaching to spine of scapula. It will be attaching to spine of scapula here. The trapezius is attaching to spine of scapula, and it can pull it back, retraction. This is called retraction of scapula. But for retraction of scapula, trapezius supplied by spinal axillary nerve, it will be held by some other muscles also, which we'll be talking in a short while, but it is retraction. Protraction, retraction. Now, what happens if there is a lesion of long thoracic nerve of bell? Then serratus anterior is not working. What happens if serratus anterior is not working? Then trapezius is more powerful. What will happen if trapezius is more powerful? It will pull the scapula towards the midline. If it pulls the scapula towards the midline, what will happen? The medial border will become prominent. The medial border will become prominent, and that is called medial winging of scapula. That is medial winging of scapula. This is case number 1, medial winging. Now let us look at case number 2. Case number 2. So as you look at case number 2, you'll find this is the midline, this is the right scapula, posterior view, and this is the attachment of the serratus anterior, and that was carrying, the serratus anterior was carrying the scapula forward, protraction, whereas on the other side it was supplied by long thoracic nerve of bell, and on the other side we were having the trapezius. This is the trapezius, and trapezius was supplied by spinal accessory nerve, and it was attaching to spine of scapula, and it was doing what is called as retraction. Now the problem is, you were operating posterior triangle, lymph node, incision drainage, you damage spinal accessory nerve. What will happen? If you damage the spinal accessory nerve, you will damage the trapezius, and retraction will not be possible. If retraction is not possible, what will become more powerful? What will become more powerful is the serratus anterior protraction. If protraction will become more prominent, it will pull the scapula lateral, and there will be lateral border of scapula becoming prominent, and that is called as lateral winging of scapula. Lateral winging of scapula. And remember, the same can happen in a third nerve injury. You might be thinking that nobody is asking us all this. Why Dr. Kaushal is teaching all this? You FMGE students will be thinking, nobody is asking all this to us. Why he is teaching all this? I am very sorry, you are mistaken. You already had been asked such questions. Examiner is preparing the ground, and one day he will ask, and then you will be realizing that okay, yes, that was important. It is important, and examiner already have asked you about the third nerve, dorsal scapular nerve, which supply muscles like rhomboid major and minor, and they also do retraction. So this is case number 3. Now remember, the muscles attach here. rhomboid minor, rhomboid major. These are rhomboid major, minor, and they're supplied by dorsal scapular nerve. What will happen if dorsal scapular nerve is gone? This is case number 3. Case number 1 was serratus anterior. Case number 2 was the trapezius. Case number 3, lesion of dorsal scapular nerve, which can happen in weightlifting or some volleyball players. Weightlifting, volleyball players, dorsal scapular nerve damage, and then rhomboid major, minor not working, retraction not working. Again, what will happen? If retraction is weak, what will happen? That will also result in lateral winging of scapula, because serratus becomes more powerful. Serratus becomes more powerful, lateral winging of scapula. So the student will ask, sir, if the examiner is asking just winging of scapula, what is my answer? Examiner is asking winging of scapula, what is my answer? Your answer is long thoracic nerve of bell, serratus anterior gone. No, sir, not given. What is the second answer? Second answer, spinal axillary nerve and trapezius. Sir, not given. What is the third answer? What is the third drug of choice? Third drug of choice is dorsal scapular nerve, rhomboid major and minor. These two will result in loss of retraction and lateral winging of scapula. That was the question. So sometimes we think that life is easy, and maybe life is easy for many people, but not for doctors. Sometimes you'll be stuck with some diagnosis, and you may not be able to diagnose the patient, but you should not let the patient die. Instead, you die trying to survive, make the patient survive. That is what a good doctor will be. Okay, so B is the answer. Yes, no doubt. This was a simple case, but in life you will get difficult patients also. Be ready for that, and don't working hard is always better. I don't know how to teach you that, but just by looking at me, maybe you will learn. Just look at me and you will learn. So can you see one thing now? Can you see one thing here? This is the medial border becoming more powerful, medial winging, and injury to long thoracic nerve, serratus anterior. This is medial winging of scapula. On the other side, this is the lateral border, which is becoming more prominent, and that is lateral winging, and that is problem injury, spinal axillary nerve, trapezius, or the dorsal scapular nerve. Dorsal scapular nerve, 2 rhomboids. Okay, right. Nipunya, B is the answer. Yes. Tiyashina, yes, very good. You already have answered. So let us move on to the next question. Then what is the yeah, tell me, did you get the answer correct or not? Because at the first go, even I made a mistake in this question. So what is your answer? Which nerve is injured if you have a fracture of the lateral condyle? We'll think that lateral condyle is related to the radius nerve, so radial nerve should be damaged, but that is not the answer. What is the answer? And why is the answer? What is the answer and why that is the answer? Answer here is the ulnar nerve. But why the ulnar nerve is the answer? This is what we call as tardy ulnar nerve palsy. This can happen in fracture medial epicondyle. Okay. Yes. Yeah. So these artificial intelligence, AI, I have all of them, paid subscriptions. I have ChatGPT, I have Google Gemini, I have Perplexity, I have Copilot, I have Xgrok, I have whatever you have, artificial intelligence, the paid version. Now they are charging too much, so I'm thinking of canceling the subscription. But ChatGPT, I ask, the answer was median nerve. Then I asked Perplexity, answer was ulnar nerve. Each artificial intelligence was giving different answer, and even my answer was different actually. So I sat and did the research work, and finally, look at the question. Which nerve is injured? Fracture lateral epicondyle. Don't think, or the best thing to tell you is, don't think. Don't think. Now, if I don't think, then how will I answer? If I don't think, then how will I answer? Answer from the books. And books, they are written on journals. Journals are written because of patients. The patients' statistics. For such questions, don't think, because you'll always think wrong answer. Even I thought wrong answer, because I'm an anatomist. I thought radial nerve is there, radial nerve should be damaged. No, don't think. Then what to do? Read the books. Which book? There are some 80 books on anatomy. Read 80 books. 80 books you cannot read, obviously, that is not possible. But then where the books are written from? Journals. Where the journals are written from? The patients. So what is the answer? Answer is ulnar nerve. Why ulnar nerve? Because the most common cause, most common should be remembered. So ulnar nerve, tardy ulnar nerve palsy. When there is a fracture medial epicondyle, there can be cubitus valgus, gun stock deformity, cubitus valgus, elbow going away, lateral, L for lateral, L in valgus, lateral, gun stock deformity, and tardy ulnar nerve palsy. Sensory loss, finger 4-5 supplied by ulnar nerve, anterior posterior. Sensory loss starts with sensory loss, and then it will be compromising the lumbrical interossei. Also later there could be ulnar claw hand deformity, ulnar claw hand deformity. So all that ulnar nerve. Now the thing is, this is how it is. If you look at the detail, you will find that we are focusing upon right-sided lower humerus. Right-sided lower humerus. Right-sided lower humerus means this is capitulum, the lateral condyle. This is the trochlea, the medial condyle. And this is the radius bone, and that is the ulnar bone here. So the nerves. You will see there is a nerve which is passing behind medial epicondyle. The nerve which is passing behind medial epicondyle is the ulnar nerve. And it can be damaged, of course, if there is a fracture medial epicondyle. If there is a fracture medial epicondyle, ulnar nerve will be damaged. But this was not fracture medial epicondyle. This was fracture lateral. Now the thing is, when somebody says lateral epicondyle damage, I'll think that radial nerve should be damaged. I'll think that radial nerve, but no, it is rarely damaged. Now, if lateral epicondyle fracture, radial nerve which is there is not damaged, then when it is damaged? Actually, radial nerve clinically is damaged when there is a fracture mid-shaft humerus. When there is a fracture mid-shaft humerus, means somewhere here, then radial nerve is damaged. So radial nerve damage is more because of fracture mid-shaft humerus. What about median nerve? Median nerve is also passing. What about median nerve? Median nerve is damaged when there is, you can say, supracondylar fracture. So just remember, fracture mid-shaft humerus, radial nerve. Supracondylar fracture, then median nerve, especially the branch anti-interosseous nerve, branch of median nerve. So anti-interosseous nerve, branch of median nerve, damage if fracture supracondyle. And what if there is a fracture lateral condyle? If fracture lateral condyle, ulnar nerve. And what if there is a fracture medial epicondyle? Ulnar nerve. So maybe lateral epicondyle or maybe medial epicondyle. Answer remains ulnar nerve. Ulnar nerve. I'll repeat again. Fracture mid-shaft humerus, radial nerve. Or when is radial nerve damage more common? When there is a fracture mid-shaft humerus. When is median nerve damage more often? When there is supracondylar fracture. When is ulnar nerve damage? When it is medial epicondyle and lateral epicondyle fracture. And this is not something easy. You will not find it in regular textbooks. But question has come. And if question has come, then you should be careful. You are not supposed to make mistakes. It cannot be median nerve. It cannot be the radial nerve. It should be ulnar nerve. But be careful. All of them can be damaged. It is not that they cannot be damaged, but less chances, rare chances. And rare incidences are rarely the answers. Rare incidences are rarely the most common answer is the most common thing which is happening. Examiner don't want you to tell rare things. Examiner want you to tell more common things. Okay. Now, this is one question, left horn of sinus venosus. So this is about the development of the heart, and they are asking left horn of sinus venosus. You know, when the heart is developing, it is a tube. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And there are some horns. This is sinus venosus, where the blood will enter. The heart tube is having 5 parts, and the blood will enter by Vitelline vein, umbilical vein, cardinal veins. So there are veins like Vitelline veins, umbilical veins, and cardinal veins. And these veins, they are bringing the blood into the right horn and left horn of sinus venosus. So the heart is developing. There's a heart tube which is developing. It has 5 parts, and the blood which comes is by cardinal vein, umbilical vein, Vitelline vein. These veins, blood is coming into right horn of sinus venosus, left horn of sinus venosus. Now, when the heart is developing, the right horn of sinus venosus will be absorbed to form the posterior smooth wall of right atrium. Right atrium, posterior smooth wall. The right horn of the sinus venosus will be absorbed to form the posterior smooth wall of right atrium, whereas the left horn become very small. The left horn will become very small and will become coronary sinus of the heart. It will become coronary sinus of the heart. And coronary sinus of the heart receives the venous drainage of the heart. Now, this is one thing. But you cannot understand this until you look at the diagrams. So let us look at the diagrams. And this is looking from the posterior view of developing heart. Posterior view. You're not looking from front view. You're looking from back, posterior view. Because from there you can see clearly. So what you see here? What I see here is, this is the left horn of sinus venosus. And that is the right horn of sinus venosus. And I see some veins bringing the blood into the sinus venosus. This is the beginning. In the beginning, there'll be a, because you're looking from posterior, so this is left, this is right. So right horn, left horn of sinus venosus, and blood is coming now into the heart. Which veins bring the blood? Cardinal veins, Vitelline veins, umbilical veins. So cardinal, like this is the left anterior cardinal vein, left common cardinal vein, this will be posterior cardinal vein, right anterior posterior common cardinal vein. So Vitelline vein will be there. What is happening to the right horn of sinus venosus? Right horn of sinus venosus is absorbed and forms smooth part of right atrium, which is called as sinus venerum in the adult heart. In the adult heart, posterior smooth wall of right atrium, this yellow color, right horn of sinus venosus forms posterior smooth wall of right atrium called sinus venerum. Our question is, what is happening to the left horn of sinus venosus? The left horn of sinus venosus is forming coronary sinus, That is what is the answer. And what is coronary sinus doing? Coronary sinus in the adult heart will collect the venous blood of the heart and put it into right atrium. Coronary sinus is going to collect the venous blood of the heart and put it into right atrium. So that is coronary sinus. So this is what they were asking. What about the superior vena cava? See, superior vena cava is present only on the right side. Superior vena cava, inferior vena cava are only on the right side. Left, they disappear. So left, they disappear, only right side. So right-sided superior vena cava and right-sided inferior vena cava. Right-sided superior vena cava is coming from the, you can see future superior vena cava coming from what? Left-sided, anterior, cardinal and common cardinal. Anterior cardinal, common cardinal. So superior vena cava comes from the right-sided, anterior cardinal and common cardinal. This one. What about the inferior vena cava? Inferior vena cava, a lot of contribution, like Vitelline vein will be contributing. Vitelline vein will be contributing, and there are others, anterior cardinal vein, posterior cardinal vein. There are a lot of things contributing to inferior vena cava. With that view, you can go back to your question, and it is asking, left horn of sinus venosus, what is it forming? So what is your answer? The left horn of sinus venosus, we already told, left horn will become very small and will form coronary sinus. And who will form the smooth part of right atrium? Smooth part of right atrium, which is also called sinus venerum, is formed by right horn of sinus venosus. It is right horn of sinus venosus. It will form sinus venerum, which is posterior smooth part of right atrium. Superior vena cava will come from right-sided anterior cardinal vein and common cardinal vein. The superior vena cava will come from right-sided anterior cardinal vein, common cardinal vein. And what about the inferior vena cava? Inferior vena cava has a lot of contribution. It has anterior cardinal vein, it has posterior cardinal vein, it has supracardinal vein, it has subcardinal vein. So there are a lot of contribution, even the Vitelline vein. So if we look at the formation of inferior vena cava, it's long discussion. Inferior vena cava contributed by not the anterior, because anterior will form superior vena cava. It is contributed by posterior cardinal vein, supracardinal vein, subcardinal vein, and Vitelline vein, a right-sided Vitelline vein, because it is right-sided structure. So everything will be right-sided Vitelline vein, right-sided subcardinal, right-sided supra subcardinal, and right-sided posterior cardinal. There is another name also, sacrocardinal. So that will be a lot of details, but here keep your answer as choice number A. What about this question? Which structure passes through median arcuate ligament? Median. This is about the diaphragm. This is about the diaphragm. And the diaphragm, you will see that there is a mnemonic voice of anatomy. And it is thoracic vertebral level. There are some openings, 8, 10, 12. So when we are talking about the diaphragm opening, voice of anatomy, thoracic 8, 10, and 12. These are major openings through which some structures will be passing in the diaphragm. V is inferior vena cava. The V is inferior vena cava, and O is esophagus, and A is aorta. But aorta, along with aorta, you will have other structures. You can remember ATA structure are passing. And what are these ATA structure passing at T12 vertebra? And they are passing through the median arcuate ligament. So in the median arcuate ligament, the ATA structures are passing, and that is what we want to talk about. Look at the diaphragm from inferior view. So when you are looking at the diaphragm from inferior view, you'll find that this is the L123 vertebra in the abdomen. L123 vertebra in the abdomen. And attaching to L123 vertebra in the abdomen, you'll find that there is a right crus of diaphragm and there's a left crus of diaphragm. Right is longer, left is shorter, and they are connected by a median arcuate ligament. So I'll repeat. Looking from inferior view, from here to the diaphragm opening, lumbar vertebra 1 to 3 in the abdomen. The diaphragm has, it is a skeletal muscle. It will have attachments on the bone. So skeletal muscle attachment, right crus is longer, attaching to L123 vertebra. Left crus is shorter, attaching to the vertebra L12. Connecting the two is median arcuate ligament. And through that pass the ATA structures. Now when you say ATA structures are passing, which vertebra will be behind? The one which is superior. Which vertebra is proximal? T12 vertebra. So at the level of T12 vertebra, or in front, anterior to T12 vertebra. Anterior to T12 vertebra, you will have ATA structure passing. Now I told you, the veins are to the right side and arteries are to the left side. Embryologically, the veins are to the right side and arteries are towards the left side. That means aorta will be to the left side. Now if the aorta is to the left side, then which vein is to the right side? That vein is called azygous vein. That is the azygous vein. So azygous vein is to the right side and the aorta is to the left side. Then what is there in the middle? What is this T? Thoracic duct. So remember, median arcuate ligament in front of T12 vertebra, you'll have ATA structures. The structure on the right will be azygous vein, left will be aorta, and in the middle will be thoracic duct. Now that is for T12 vertebra. What about the esophagus? If you talk about esophagus, you'll see the right crus of diaphragm will be making an opening. The right crus of diaphragm is making opening, and through that opening comes the esophagus. That is the esophagus. So esophagus at which level? Which vertebra? T10 vertebra. This is T10, this is T12. The right crus of diaphragm will be making an opening through which the esophagus is passing, and that is T10 vertebra. And still higher if you go, you'll find there is a central tendon of diaphragm, and the central tendon of diaphragm will be inferior vena cava. As I told you, inferior vena cava will be more to the right side because veins are more to the right side, and this will be T8 vertebra. T8 vertebra, highest. So central tendon of diaphragm, that is the central tendon of diaphragm, and central tendon of diaphragm towards the right side, you will have the inferior vena cava opening, T8 vertebra. So as I told you, voice of anatomy, voice of anatomy, V for inferior vena cava, voice of anatomy is O for esophagus, and T12 voice of anatomy A for the aorta. And this inferior vena cava, which is passing through the central tendon, will be accompanied by right-sided phrenic nerve, right-sided phrenic nerve, right phrenic nerve. Now, once you have this information with you, let us look at the diagram which we normally use, and your diagram is here. This is the diagram. So let me repeat the things. As you can see, this is right crus of diaphragm, that is left crus of diaphragm. Connecting the two is the median arcuate ligament. In the median arcuate ligament, you can see that this is the aorta to the left side. Then there will be azygous vein to the right side, and in between will be the thoracic duct. So ATA structure, median arcuate ligament, T12 vertebra. Then you will see the right crus of the diaphragm sending one opening for esophagus. So that is the esophagus. Here it is esophagus. And then you can see for yourself in the central tendon of diaphragm. This is the central tendon of diaphragm. The central tendon of diaphragm, you can see the inferior vena cava and the right phrenic nerve. This will be T8, thoracic 8 vertebra. So thoracic 8 vertebra, the central tendon with inferior vena cava, thoracic 10 vertebra, right crus of diaphragm, esophagus, and thoracic 12, the ATA structure in the median arcuate ligament, the openings in the diaphragm. Yes, G Unlimited, you are correct. Central tendon comes from septum transversum embryologically. Embryologically, it is coming from septum transversum. That is correct. So with all this information, you can come back and you can find your answer. What do you think is your answer? As you see, which structure passing through median arcuate ligament, T12 vertebra, ATA structure. So if you say ATA structure, then your answer is aorta. Not only aorta, but you will have thoracic duct, and along with thoracic duct, you will also have the azygous vein. So they are all passing there. What about esophagus? Esophagus is in the right crus of diaphragm, T10 vertebra. What about inferior vena cava? Inferior vena cava, T8 vertebra in the central tendon of diaphragm, along with right phrenic nerve. So both of them, right phrenic nerve, right side of midline, inferior vena cava in the central tendon of diaphragm, T8 vertebra. But keep your answer as the aorta here. Then as you move further, you will see this question. What is your answer? I think you would already have marked it correctly, and it is asking which congenital deformity is shown. So there is anencephaly and the rachis. Anencephaly and then there is rachis. Now what is this together? Together this is called cranio-rachis. Yes, G Unlimited, B is the answer, that is correct. So cranio-rachis. What is anencephaly? Anencephaly happens if we have the non-closure of anterior neuropore. So if we have non-closure of anterior neuropore, which is happening by day number 25, the anterior neuropore should close, brain will form. By day number 25, anterior neuropore should close, brain will form. If it doesn't close, open, neural tube defect. Open neural tube defect. Why? Non-closure of anterior neuropore, and which should happen by day number 25. It doesn't happen. Anencephaly. What is anencephaly? Small degenerated brain, skull cap is missing. Small degenerated brain, skull cap is missing. That is anencephaly. What about the posterior neuropore? Posterior neuropore, what can happen is it has to close by day number 28, and non-closure of the posterior neuropore can result in rachis or spina bifida. Spinal cord is open, CSF leaking out. So spina bifida, spinal cord is open, CSF leaking out. That is non-closure of posterior neuropore, and that is rachis. But if entire neural tube is open, then you call it as craniorachis. Sometime you may find that there is spina bifida but occulta. Occulta means hidden, means you don't know that there is a case of spina bifida, and it is some incidental finding. By some mistake you have found incidentally, you were taking some x-ray and you found it. So spina bifida occulta can be, the occult means hidden, or it could be meningomyelocele. Spina bifida with meningomyelocele means meninges are coming out and spinal cord is also coming out. Meninges coming out, spinal cord coming out, spina bifida. So there are many variations, but here you keep your answer as choice number B. Let me show you a diagram now. As you see, these are open neural tube defects. So as we discussed the closure of neural tube, this is the neural tube. Anterior neuropore, cranial neuropore should close by day number 25. Day number 25, anterior cranial neuropore should close. And on the other hand, the posterior neuropore, caudal neuropore, should close by day number 28. Day number 28. All of these are MCQs, your FMGE questions. FMGE questions only. That anterior neuropore, day number 25 should close, and if it is not closing, then anencephaly. Small degenerated brain, skull cap missing. Small degenerated brain, skull cap missing. And day number 28, posterior neuropore should close. If it is not closing, spina bifida problems. Like you see this. Now, what is this open spina bifida? Maybe meninges are coming out. The spinal cord is also coming out. So you'll find a cyst. In that cyst, you will have CSF, and in that CSF, you will have spinal cord matter. So meningomyelocele. Spina bifida with meningomyelocele. So these are all problems of posterior neuropore. And if it is a problem of anterior neuropore, then anencephaly. So I think latest one question has come, some pointer here. They have put some pointer here asking what is the structure. So somites are there, anterior neuropore, posterior neuropore. Maybe they were marking here on what is called as neural fold. I think the students were telling question was on neural fold. This is the INICET exam, latest INICET exam. We are just trying to find out, trying to find out what was the question, exact question, like that. Now, what about this question? It is asking triparepithelium in the diagram. As you look at this diagram, you will immediately notice that it is having large globular cells towards the surface, apices. And if you have large globular cells, and it is a multi-layered appearing epithelium. And with large globular cells towards the lumen or towards the surface, it is going in favor of the transitional epithelium. Transitional epithelium means ureter. So it is a diagnosis of transitional epithelium and ureter. But how will you identify ureter from trachea? Trachea will have pseudo-stratified ciliated columnar epithelium with goblet cells. What the trachea will have? Pseudo-stratified ciliated columnar epithelium with goblet cells. And what the duodenum will have? Duodenum will have striated border. There will be microvilli with columnar cells. So columnar cells with the microvilli, striated border. I'll show you the diagrams also. Duodenum will have striated border. It is small intestine. Small intestine, there'll be some goblet cells also and microvilli. What about skin? Skin, you will have the stratified squamous epithelium with the keratin. Stratified squamous epithelium with keratin. So can you show all the slides, because examiner will be asking. So these are the slides. As you look at the slides, you will find that the very first which you are looking upon is pseudo stratified ciliated columnar epithelium with goblet cells are not very clear, but there will be goblet cells if you are talking about trachea or bronchus. So trachea and bronchus. Trachea and bronchus, I'm sorry, pseudo-stratified ciliated columnar epithelium. You can see cilia here. These thread-like processes, they are cilia. So cilia, your eye should be able to identify, and you should also be able to identify the pseudo stratification. If you want, I can zoom it a little bit. This is how it will appear. Pseudo stratified ciliated columnar epithelium. C is for cilia. C is for cilia, pseudo stratification. Okay, what is the number 2? Number 2, you can see keratin. K for keratin. This is K. K is for keratin, and this is, you can see, this is a multi-layered epithelium. Multi-layered epithelium, and even the superficial cells, they are not very large cells, not very large. They will be flat cell, flat nucleus. So flat cell, flat nucleus, stratified squamous epithelium, which is keratin. So this appears in the skin. In the skin, you will have stratified squamous epithelium with keratin. So skin will appear like that. The topmost cells will be having flat cell, flat nucleus, flat cell, flat nucleus. In comparison to the globular cells, which we were talking about, umbrella shaped cells. So globular or umbrella shaped cells, that is transitional epithelium. U for urothelium or transitional epithelium. So U for urothelium, or what is called as transitional epithelium. Like one example we have taken was the ureter. We were talking about ureter. So ureter will have urinary epithelium. How will you identify this? I identify this by the fact that it is umbrella shaped cell. Can you see the umbrella shaped cell? This is a large cell and appearing like an umbrella. And under the umbrella, you can see there are some other cells like 1, 2, 3, 4. So like rain of the urine, urinary bladder, ureter. There is urine in the urinary bladder, ureter, and there umbrella cells are there. Under the umbrella, you have 3, 4 cells other. So it is a large cell, globular cells towards the lumen, and that is how you will identify it from the stratified squamous. Stratified squamous, the topmost cell is flat cell, flat nucleus, but here it is large globular cell. So this is transitional, and that is stratified squamous. This is stratified squamous, this is transitional. What about the duodenum? Duodenum, we have seen, this is microvilli. That is how the microvilli will appear. These microvilli, columnar cell with microvilli. This pinkish line, what you see, this pinkish line is what you see is called as the microvilli. It is called as striated border, and that striated border can be seen in the duodenum. That can be seen in the duodenum. It is simple columnar cells with microvilli. Simple columnar cells with microvilli, striated border, duodenum. So the point is, sometimes the students might be thinking, oh, what are we doing? What is happening? Who is this faculty teaching so much? We are not in habit of being taught like this. What is this? Some aberration has come. Let us run off. Let us close everything, and let us just go and sleep or watch some movie, or some TV series has come. Why should we spend time with Dr. Kaushal? And then you should realize what is your result. When 100 students sit, how many pass? And why they don't pass? I have a simple question. 100 students sit in FMGE, only 10 to 20 pass. What about the rest of the 80? Why they don't pass? I think you know the answer. So work hard, and you should know that pseudo-stratified ciliated columnar epithelium with goblet cell, trachea bronchus should appear like this. And this is not something new, means nobody is asking and I'm teaching. No, everything is being asked. We teach only those things which are being asked and which can be asked again. So what is this? This is stratified squamous with keratin. This is skin. This is the urothelium, large globular cells towards the apex. This is ureter, you've seen, urinary bladder. This is the striated border microvilli, the duodenum or small intestine. Even the gallbladder, that comes as a question, can have this appearance. So as you see, the answer to this question you already have given. Type of epithelium shown in the diagram, your eyes should be able to identify. Train your eyes for that. And this is transitional epithelium. Transitional epithelium means ureter. Choice A should be your answer. How trachea is seen, how duodenum is seen, how skin is seen. I told you how to practice one MCQ. One MCQ you have to practice in such a way that you should know what is the answer. This is the answer. But why this is the answer? Why others are not the answer? And when they will become the answer? Because next time this won't be the question. Next time this won't be the question. The examiner will change the question. Then what will you do? You'll answer the ureter only. Then you'll answer ureter only. Then you'll be wrong. You will not pass. So how do I pass? You work hard and smart. How do I work smart? Asking questions to yourself. Why, what, when? That is how you become smart. And you cannot become smart until you work hard. You work hard. And we'll teach you to work hard, your teachers. But your teachers tell you, what is this? This is so simple. Last time I taught you, and this is the answer. Let us go to the next question. This is how your teachers teach. And you learn the same thing. You learn being callous, you learn being easy, you learn being lazy, and you are not getting successful. Getting successful is coming out of your comfort zone. Learn it now or you'll learn it later. Okay, so patient present with pain, restricted movement, pubis symphysis. This is artificially created clinical question. You know what is the answer. Pubis symphysis is a midline joint. It is secondary cartilaginous joint, and it is called as symphysis. It is symphysis. So secondary cartilaginous, so symphysis. That is the answer. Okay, pubis symphysis. As you talk about the joints, you can see that there is a syndesmosis. Desmos means fiber. It is a fibrous joint. Syndesmosis, fibrous joint. Like we'll discuss three of them later. Synchondro. Chondro is cartilage. This is primary cartilage joint. Primary cartilage joint. I have a table. In that table we'll discuss. And synovial joints can be multiple. So, but keep your answer as choice number C here. And look at this table. You can quickly revise your joints classification. So joint classification based upon the freedom of movement. The freedom of movement, how much movement is available. Say fibrous, they are almost immobile. Cartilaginous, slightly mobile. Synovial, freely mobile. And when you say the fibrous three type. One is the sutures, which can be seen in the skull. And the other is gomphosis. Gomphosis like tooth and socket. And this is the syndesmosis we were talking about. Syndesmosis like the middle radial ulnar joint. I'll repeat. According to freedom of movement, the joints can be classified fibrous, cartilaginous, or synovial. Fibrous, three subtypes. Sutures in the skull, like this is between the nasal bone, vomer, and sphenoid. Nasal bone, vomer, and sphenoid. Sphenovomerine joint. Sphenovomerine joint is a suture. And then tooth and socket, gomphosis, is a fibrous joint. And middle radial ulnar joint is a syndesmosis, a fibrous joint. Then comes the cartilaginous. Cartilaginous, this is primary cartilaginous joint, also called as synchondrosis. Primary cartilaginous synchondrosis like epiphysis, diaphyseal joint in the growing children. Epiphysis, diaphysis joint in the growing children is primary cartilaginous synchondrosis. And if you talk about pubis symphysis, this is symphysis, or you can call it as secondary cartilage joint. So secondary cartilage joint, symphysis. Another example will be midline intervertebral joint. Midline intervertebral joint, where you have intervertebral disc. This is also a symphysis, slightly mobile joints. These are slightly mobile joint. So pubis symphysis or intervertebral joint in the midline, there will be symphysis, secondary cartilaginous joint. When it comes to synovial, there will be multiple types, and we are not going into multiple types here. Our purpose was to focus upon the question, and the question which we already have answered. The question was asking about pubis symphysis, and pubis symphysis means it is secondary cartilaginous joint. Now, as we move on to this, patient is having a problem with the dorsiflexion, weakness of dorsiflexion of the foot and loss of sensation over the dorsum of the foot. That is what G Unlimited pointed out. So there's a clerical error in the question. What is the clerical error? Patient presents with weakness of dorsiflexion and loss of sensation. Remove this. That was the question actually. This thing, you remove it, then it becomes a correct question. So that was the error. That was the error. The actual question was, patient presents with weakness of dorsiflexion and loss of sensation over area between the great toe and the second toe. That means the answer is deep peroneal nerve, because it is the one which supplies the area. So there was some line to be deleted which couldn't be deleted, and that was in 20 MCQs. This is the only mistake, I think, and that mistake was spotted by G Unlimited. So deep peroneal nerve is the answer. Now, why that is the answer? Let us find out. See, if you take a transverse section of the, say this is the midline, this is right leg. That is the midline, that is right leg. In the right leg, you take a section, transverse section. So midline of the body, left, right leg. Take a section, you will find in the leg there are 3 compartments. In the leg, not the thigh, leg, below knee. Below knee, leg will have 3 compartments. There is a lateral compartment, and there is a posterior compartment, which is also called calf, and then there is anterior compartment. So this is anterior, this is posterior, this is lateral. In the leg, below the knee, you have 3 compartments. So which muscles are there in the lateral compartment? Lateral compartment, you have some muscles called peroneus longus, peroneus brevis, and they are lateral. They turn the sole lateral, which is also called foot eversion, and they are supplied by a nerve which is called as the superficial peroneal nerve. I'll repeat the information again. In the leg, there are 3 compartments. Lateral leg compartment turns the sole lateral, turn the sole lateral, foot eversion. So that foot eversion is done by the peroneus longus brevis, supplied by superficial peroneal nerve, lateral. Now come to the anterior leg compartment. Anterior leg compartment, you have a nerve called anterior tibial nerve, because it is anterior to tibia. It is also called deep peroneal nerve. So anterior leg compartment, you'll have the anterior tibial nerve, anterior to tibia, and it is also called deep peroneal nerve. It will supply some of the muscles. You can remember by the mnemonic, the extensor, Tom, Dick, and Harry. Extensor, Tom, Dick, and Harry. Now, when you say extensor, Tom, Dick, and Harry, who is this Tom, Dick, and Harry? Extensor are tibialis anterior, extensor digitorum longus, extensor hallucis longus. So they are all extensors. As the name is telling, tibialis anterior, anterior to tibia, and D, extensor digitorum longus, and H, the hallucis. Hallucis means great toe. You want to extend the great toe, and digitorum means extend the other toe, and they are extensors. Extensors means this deep peroneal nerve is the nerve of extension. Extension means dorsiflexion. So the muscles which are here, the extensor, Tom, Dick, and Harry, are dorsiflexors at the ankle and the toes, and the root value, if you should remember the root value also, is L5. It is L5. Now, if you remember that the root value is L5, on the posterior side, here you will be having S1 root value, and there will be calf muscles, and the calf muscles, there will be a lot of calf muscles, but you can remember flexor, Tom, Dick, and Harry. Flexor, Tom, Dick, and Harry. Now, if it is flexor, Tom, Dick, and Harry, what are their names? They are the mirror image, but what is the name? Behind the tibia. So Tom, Dick, and Harry. Tibialis posterior, This is flexor digitorum longus. This is flexor hallucis longus. If they are extensors, they are flexors. Anterior leg, extensor compartment. Posterior leg, flexor compartment. Flexor, Tom, Dick, and Harry. So who is this flexor, Tom, Dick, and Harry in the calf region? In the calf region, flexor, Tom, Dick, and Harry are tibialis posterior and flexor digitorum longus, flexor hallucis longus. Means they will fold the toe digitorum longus, fold the great toe, flexor hallucis longus. And what is the nerve supply? Nerve supply is behind the tibia. So posterior tibial nerve. There will be posterior tibial nerve with root value S1. So if it is posterior tibial nerve with root value S1, it will be antagonizing the L5 of antitibial nerve. Yes. What is antitibial nerve doing? Dorsiflexion. What is the posterior tibial nerve doing? Plantar flexion. Plantar flexion. So this is for dorsiflexion of an ankle, foot, and this one is for plantar flexion. Yes. Okay, right. So patient presents with weakness of dorsiflexion. Are you talking about anterior tibial nerve, which is also called deep peroneal nerve? Yes. Are you talking about extensor, Tom, Dick, and Harry? Yes. Extensor, Tom, Dick, and Harry, not working. Are you talking about L5 root value? Yes, we are talking about L5 root value. Are you talking about this group here? Yes, I am talking about this group here. So what is the sensory loss? On the foot, this first interdigital cleft. On the foot, this first interdigital cleft is L5 dermatome, deep peroneal nerve, and that is the sensory loss. Area between great toe and second toe on the foot, not the hand, foot. So the answer is deep peroneal nerve. Yes. What if superficial peroneal nerve is not working? If superficial peroneal nerve is not working, then you know it will have two branches, deep peroneal nerve and superficial peroneal nerve. None of that will be working. So if sorry, this is common peroneal nerve. So just this is common peroneal nerve. Common peroneal nerve gives two branches. So common peroneal nerve gives two branches, deep peroneal and superficial peroneal nerve. If deep peroneal nerve is not working, you have seen what happens. What about superficial peroneal nerve? Superficial peroneal nerve is here. This is superficial peroneal nerve. Loss of foot eversion. There will be loss of foot eversion. So superficial peroneal nerve is compromised, then you'll have loss of foot eversion. What about tibial nerve? Tibial nerve is simple name for posterior tibial nerve. Calf muscle will be involved. Calf will be involved. Tibial nerve, when you say tibial nerve, it is understood it is posterior tibial nerve. So that is calf will be involved. And what about sural nerve? Sural nerve is a branch of tibial nerve. Root value will be same, S1. S1 only. Both of them, they have S1 root value. So what is sural nerve supplying? Little toe, dorsum of little toe, lateral margin in the foot, Anyway, keep your answer as choice number A, and then you can look at some details here. Sensory supply, if we are talking about, I have just mentioned one thing. If it is dorsum of the first web space, then it is the deep peroneal nerve. Otherwise, most of the dorsum is supplied by superficial peroneal nerve. Most of the dorsum is supplied by superficial peroneal nerve. So most of the dorsum, superficial peroneal nerve, except for the first interdigital space, because that is supplied by deep peroneal nerve, L5. That is L5 dermatome. And sural nerve, as I told you, little toe. Sural nerve is little toe. This is sural nerve S1. That is S1. So little toe S1, this great toe area L5. And if you want to know, medial malleus is L4. That will be saphenous nerve. That is different nerve. So medial malleus L4, great toe L5, little toe S1, L4, L5, S1, L4, L5, S1. S1 is a branch of, it is not femoral nerve, written wrong here, tibial nerve. It is a branch of tibial nerve. Tibial nerve branch, the sural nerve S1, little toe, and deep peroneal nerve, the first interdigital cleft. With that overview, you could have answered this question. So as you see, and this dorsiflexion, you know what is that called? Loss of dorsiflexion, foot drop. That is a case of foot drop. This is a case of foot drop. This is a case of foot drop because you are unable to do dorsiflexion. So this is a case of foot drop with loss of sensation in the first interdigital cleft. And it is a problem of deep peroneal nerve. Okay. All right. Now, I think the last question we are left with. No, there is one more. One is on artery. So what about this question? It is asking the same thing which you have discussed briefly. Patient with low backache radiating to posterior aspect of right leg, and examination of weakness of plantar flexion. Plantar flexion, right foot, and ankle jerk is gone. Ankle jerk is S1. S1, and it is plantar flexion only. Plantar flexion. And which spinal nerve root? It is a slip disc case. Slip disc. So it is a case of slip disc, and as you see, plantar flexion. See, I told you what is dorsiflexion? L5. What is plantar flexion? S1. L5, S1. So this is a problem of S1. Now, if you say it is a problem of S1, where was the slip disc? Can come as a question. If S1 is your answer, fine, because there is a problem of plantar flexion. That is a value of, and you know who is doing this? This is all done by flexor, Tom, Dick, and Harry. Flexor, Tom, Dick, and Harry. If you remember, tibialis posterior, flexor digitorum longus, flexor hallucis longus. Flexor, Tom, Dick, and Harry, which were there in the calf region. We have discussed S1 for plantar flexion. It is the flexor, Tom, Dick, and Harry, which were behind in the posterior compartment of leg. Flexor, Tom, Dick, and Harry, tibialis posterior, flexor digitorum longus, flexor hallucis longus. They were doing flexion. And what was the nerve? Posterior tibial nerve. Posterior tibial nerve with root value S1. So that has been compromised. But where is the slip disc? That is a question. And for that, you can see this diagram. This is what our patient is. Remember, when we are talking about the slip disc, say this is the slip disc. You know, there is posterolateral herniation of nucleus pulposus. Posterolateral herniation of nucleus pulposus. Posterolateral herniation of nucleus pulposus, that is slip disc. And if it is between L3-4 vertebra, L4-5 vertebra, or L5-S1 vertebra, that is what. Remember that the nerve which is involved is next nerve. Next nerve. That means if I am having the vertebra number L4 here, vertebra number L5 here, vertebra L4, L5, which nerve will be passing between them? The nerve passing between them will be actually the L4 nerve, but that is not involved. The next nerve is involved. L5 is involved. Now, why L5 is involved and why not L4 is involved is also a logical thing. L4 vertebra, L5 vertebra, which nerve passes between them? L4 nerve. Then why L4 nerve is not involved? Why the next nerve, L5, is involved? Because the slip disc is going in such way that it is compressing the next nerve. But if it is compressing the next nerve, how can I remember if a question comes, L4, L5 slip disc, which nerve is involved? So I have a trick there. Simply remember, whatever the upper vertebra is, add +1, that nerve is involved. Whatever the upper vertebra is, add +1, that nerve is involved. What is this trick? Cannot understand. If you do not understand this trick, simply say L4, L5, S1. L4 vertebra, L5 vertebra, S1 vertebra. Now examiner has given you a slip disc between L4 and L5. Which nerve is involved? L5, S1. Which nerve is involved? My trick is simple. Upper vertebra +1 means if they are telling L4, 5 vertebra slip disc is there, upper vertebra is L4, +1 is L5. So L5 nerve is involved. And here L5, S1, then which nerve is involved? L5 +1. L5 upper vertebra +1, L5 +1. But when you say L5 +1, there is no L6 nerve. It means the next nerve. So if there is no L6 nerve, next nerve, who is the next nerve? That is S1. So here it will be S1 and there it will be L5. Upper vertebra +1 is what you can use, like here. Herniated disc is between L5 and S1. Who is the upper vertebra? L5. So L5 +1 is L6. But we do not have L6 nerve. It means, simply means the next nerve. Who is the next nerve? S1. So that is your case. This case has come to you. This patient will have the dermatome affected and little toe burning sensation will be there. This patient will have little toe burning sensation here. there'll be little toe burning sensation. And which muscles compromised? Calf muscles. Calf muscles are compromised, like flexor, Tom, Dick, and Harry. Flexor, Tom, Dick, and Harry will be compromised. So which movement will be compromised? Plantar flexion. Plantar flexion. And which reflex is gone? The ankle reflex is gone. Which nerve is that? Tibial nerve, which is the other name of posterior tibial nerve. The tibial nerve name means posterior tibial nerve. And what are you doing here? I am taking a knee hammer and hitting the tendon of posterior leg muscle, calf muscles. So when you hit the tendon of posterior calf muscle, what happens? Plantar flexion. What is the root value? S1. It is plantar flexion, it is S1. So is it working in this patient? No. Why it is not working in this patient? Because S1 nerve root is not working. And if S1 nerve root is not working, where was the slip disc? It was L5 S1. It was L5 S1. L5 S1. This nerve root was compromised. Why not L5? Because the posterolateral herniation is such that it is not affecting the nerve exiting the level. It will affect the next exiting nerve. Now, if you have got all that information, you would have already reached your answer. Your answer is S1 here, choice number C. And then as you proceed further, you can see this question. It is a patient who is having acute limb ischemia, lower limb, and examination, no palpable pulse in the posterior tibial artery, but dorsalis pedis is working. Posterior tibial is not working. So where is the blockage? That is the question asking. So for that, you can draw the arteries. Say this is the midline of the body, and you're looking on the right side. So this is the femoral artery. Femoral artery continues as popliteal artery. So looking from the front view, this is right side femoral artery becoming popliteal artery, and popliteal artery then is giving us anterior tibial artery, which later becomes dorsalis pedis artery on the foot. So this is the femoral artery becoming popliteal artery. Popliteal artery will give anterior tibial artery, which will become dorsalis pedis artery. On the other hand, if you follow, you can see that the other one is called tibio-peroneal trunk, because now it is giving us posterior tibial artery and the peroneal artery. So that is why it is called as tibio-peroneal trunk. I'll repeat again. The artery which you see here is femoral artery becoming popliteal artery, and then popliteal artery divides into two. One of that is anterior tibial artery, later becoming dorsalis pedis artery on the dorsum of the foot, and the other one is the tibio-peroneal trunk. Tibio-peroneal trunk itself will give two branches, and as you can see, one of that is the posterior tibial artery, and the other one is the peroneal artery. Let us say this color, peroneal artery. That is why it is called tibio-peroneal trunk. Now, what the case is? Case is dorsalis pedis artery is working. That means anterior tibial artery is working. That means popliteal artery is working, femoral artery is working. One thing clear. If dorsalis pedis artery is working, anterior tibial artery is working, popliteal artery is working, femoral artery is working, then which one is blocked? I cannot find pulse in posterior tibial artery. If you cannot find pulse in posterior tibial artery, then where is the block? Must be somewhere here. Popliteal artery is fine. Then only the anterior tibial artery, dorsalis pedis artery is fine. Till here, no problem. So problem is here. Your answer is tibio-peroneal trunk. Tibio-peroneal trunk. That is your answer. Choice number B should be your answer. Okay. So that is all I wanted to talk about. If you wish, I can show you the details here in the diagram. You can see for yourself. This is front view. From the front view, you cannot see the popliteal artery. From the front view, what you can see is only the femoral artery. So from the front, you can see the femoral artery, because popliteal artery goes behind the knee. So when it goes behind the knee, it is shown here. But then again, you can see one artery which is coming anterior, and that will be anterior tibial artery becoming dorsalis pedis artery. So that will be anterior tibial artery becoming dorsalis pedis artery, and that thing can be shown here now. This will be anterior tibial artery becoming dorsalis pedis artery. So here you see this is the anterior tibial artery becoming dorsalis pedis artery. This is dorsalis pedis, that is anterior tibial, and that was the femoral artery from the front view. Now let us look from the posterior view. As you look from the posterior view, again you can show this is the femoral artery, but now it is coming behind the knee joint. As it comes behind the knee joint, it has become popliteal artery. So this is the popliteal artery, and as you show, this is the popliteal artery. Popliteal artery would have given two branches, one which goes anterior, that is anterior tibial artery, can be seen here. It is going anterior, so we cannot follow it much from behind. That will be the anterior tibial artery. But then posteriorly you have a trunk, and what is that trunk called? That trunk is called as the tibioperoneal trunk. Now why it is called tibioperoneal trunk? Because it gives two branches, one here and one here. One is the posterior tibial artery, and the other is the peroneal artery. So that is why it is called tibioperoneal trunk. You can show the arteries: posterior tibial artery, which is giving the sole branches like medial plantar artery, and then you have the other one, which is the fibular artery, or also called peroneal artery. They're the same. So where is the block? Block is in the tibioperoneal trunk. If you have a block in the tibioperoneal trunk, then you'll have less pulse in posterior tibial artery and the sole, medial lateral plantar arteries, and of course the lateral leg compartment, peroneal artery, will also be getting compromised. So block is here. Why not the block is in the popliteal artery? Because if the block was in the popliteal artery, then there will be problem with anterior tibial artery, and there is no such description because dorsalis pedis pulse is okay. If dorsalis pedis pulse is okay, that means anterior tibial artery is okay. That means popliteal artery is okay. Problem is beyond that. Problem is with tibioperoneal trunk, and this all we check when we are talking about cases of thromboangiitis obliterans called as Berger disease. So Berger disease, peripheral vascular disease. So when we are talking about peripheral vascular disease or Berger disease, thromboangiitis obliterans, chronic smoker 40 years male, chronic smoker 40 years male, then you have to check the pulses and identify the region and put stents, and advise him quit smoking. Okay, so that is all today we wanted to cover. We started at 7. It's almost 2.5 hours. I think we have covered quite significant number of topics, and I'm very hopeful whatever topics we have completed, there should come a lot of questions from them. Then only our efforts will be fortified. So all the best, take care, and V for victory.